and the reflection coefficient is 1. So yung answer here is D. Sabi nga natin, pag effective osmoles, nare-reflect sila. Hindi nakapag-pass through sa membrane. Para dito lang sila mag-stay. Magiging osmotically active agent sila, drawing water. So example natin na effective osmol, di ba, mannitol, which is a diuretic. So take note, pag reflection coefficient is 1, all are reflected back. Pag 0, yung reflection coefficient, yun yung ineffective. Baka mapagbaligtad niya yan. Ito, which of the following is correct regarding intracellular fluid and extracellular fluid? Yung ICF ba contains more potassium than the extracellular? ECF is part of the ICF, or majority of the body's water is in the ECF, or the ICF contains more sodium than the ECF? So the answer here is A. Yung intracellular, again, ito lang tatandaan mo. Know this by heart kasi hanggang second year, third year magagamit nito. Yung major intracellular nyo is your potassium, magnesium, phosphate. Major extracellular, sodium, chloride, and calcium. So intracellular, sa loob ng cell, yan. Huwag kayo malito sa mga spaces, no? Intracellular sa loob ng cell. Interstitial fluid, ito. Between the plasma or your blood vessels and your cell. Yan yung interstitial fluid. And your plasma is your intravascular fluid. Intravascular, sa loob ng blood vessels. So these two, ito yung extracellular fluid. So yung A, yung ICF contains more potassium. Yes, kasi major intracellular ions yung potassium. So mas maraming potassium sa intracellular. Ito, the ECF is part of the ICF. Hindi. Yung ECF lang is interstitial fluid and your plasma. So hindi yan. Majority of the body's water is in the extracellular fluid. Hindi. Yung major major water, body's water is mainly intracellular. Mamaya makikita, may table tayo doon. And yung ICF contains more sodium than the ECF. Hindi. Yung sodium, again, major extracellular siya. So sa labas siya ng cell, hindi sa intracellular. Ayan. So yung, para masagot mo yung major body of water is in the ICF, ito. Di ba may total body of water tayo? So divided siya into extracellular and intracellular fluid. Yung intracellular, ayan, mga 40% of their body weight. Kaya majority ay nasa intracellular. Yung extracellular, further divided pa yan again into your interstitial fluid, itong space na yan, or your plasma. Ayan. So mas maraming interstitial fluid kaysa sa plasma. Okay, so next. Which of the following statements concerning phospholipids is false? All phospholipids have a glycerol backbone. They have two distinct regions, one strongly hydrophobic and the other is strongly hydrophilic. False, so this is correct. Amphipathic, yes. Kasi pag sinabi mong amphipathic molecules, they have a hydrophobic portion and a hydrophilic portion. Ano nga ulit? Di ba yung lipid bilayer? Yung head is hydrophilic. Yung tails, dalawang tails, hydrophobic. So tama, amphipathic sila. Constitute around 25%. Yes, tama. So ito hindi. Not all phospholipid have a glycerol backbone. Tandaan nyo rin tong 25%. Ayan. Dito tayo sa cell volume regulation. So cells in a hypotonic solution. So hypotonic, konti lang yung osmoles sa solution compared sa cell. Mas marami sa cell. So saan yung movement ng water? Paloob ng cell. So magkakaroon ng cellular swelling pag hypotonic yung solution. So ini-utilize sila potassium chloride supporters. Ano bang ginagawa niya? Reduces cellular potassium chloride and organic osmolytes. Yes, para mabawasan yung osmolytes. Pero increasing the intracellular osmotic pressure, tama ba yun? Binawasan na nga natin ng potassium chloride yung cell, tapos i-increase pa yung intracellular. So this is wrong. Increases cellular potassium chloride, hindi. Kasi potassium chloride, in a hypotonic, rini-release niya. Tinatanggal yung potassium chloride para bumawas yung osmosis sa cell. So hindi siya increase sa cellular. Ito, reduces cellular potassium chloride organic osmosis, decreasing the intracellular osmotic pressure. Yan. Ito yung tama. So again, pag sinabi mong non-isotonic volume regulation, you have the regulatory volume decrease, which happens when the cell is swollen. Kailan ba naging swollen yung cell? In a hypotonic solution. So yung ginagawa ng potassium chloride, i-release niya out of the cell para mag-decrease yung intracellular osmotic pressure and bumalik siya sa normal volume. Compared naman sa regulatory volume increase when the cell is crenated or shrunk in a hypertonic. Hypertonic naman to. Ito naman yung papasok sa loob ng cell, your sodium potassium chloride. Ano nga ulit yung sa isotonic volume regulation? Pag isotonic, that is your sodium potassium pump. Okay. Next, parietal cells in the stomach pump hydrogen ions out of the cell via this type of transport of parietal cells. Yung stomach, pinapump niya yung hydrogen ions or your proton pump. So this is this a primary active antiport, uniport, or secondary active symport countertransport? So the answer here is B, primary active uniport. So we have these active transports, no? Uniport, isa lang yung lumalabas na cell or pumapasok. Uniport, like example yan, hydrogen pump or proton pump. Yan. Your parietal cells na hydrogen pump, the stomach. Or your circa in your muscles. Isa lang yung nilalabas niya or pinapasok na calcium. Pag antiport, yan, example nito is your sodium potassium pump. Tandaan nyo, antiport siya and primary active transport. When you say primary, it directly uses ATP. Compared sa secondary active transport, they indirectly uses ATP. So ito lang yung visuals. Uniporter, isa lang. Pag symport, example yan, SGLT. SGLT transporters yun. Yung sodium tsaka glucose sabay yan papasok. Yan example. Countertransport, pag secondary, example na sodium calcium exchanger. Lalabas yung calcium, papasok yung sodium. Yan, example yan yung sa cardiac muscles. Yan. Okay, that's all for cell physiology. Let's move on to blood physiology. So we have this regulation of blood volume consisting of your Starling forces. So yung Starling's forces, basically ito yung four primary forces na nagdedetermine whether yung fluid will move to the interstitial or in the opposite direction. We have these four. Important to. Your capillary hydrostatic pressure. Ito yun, capillary hydrostatic pressure. Interstitial hydrostatic pressure. So yung capillary hydrostatic pressure sa loob ng blood vessel, ito. Interstitial hydrostatic pressure, yung pressure ng water dito na pinupush back yung water. And you have this important oncotic pressure. Ano nga ba yung primary determinants ng oncotic pressure na? That is your plasma proteins, specifically albumin. Ayan. Sobrang important nito ha. Kahit sa mga pathologies, lagi yung na-encounter nyo. Interstitial oncotic pressure. So yan basically yung four Starling forces. And if the sum of these forces, pag yung net filtration pressure positive, ibig sabihin, it favors filtration. Ito, if favor na filtration, capillary to the interstitial. Or pag negative, favors absorption from the interstitial space into the capillaries. Pabalik naman dito. Di ba nga sa vascular physiology, yung arteriolar end, siya yung more on sa filtration, yung venule end, yun yung more on sa reabsorption, babalik. Kasi may albumin, hindi na-filter yung albumin. Yung plasma proteins, nandyan lang yun sa plasma. So yun yung oncotic pressure. Pabalik, nire-reabsorb niya yung fluid na na-filter sa capillaries. Important yun para hindi magkaroon ng edema. We have the hemoglobin. Diba siya yung nag-carry ng oxygen throughout the body. It's a combination of your hemoglobin. Ito yung globin change. So, your alpha 1, alpha 2, beta 1, beta 2. So, your 2 alpha 2 beta, that is adult hemoglobin, your hemoglobin A, diba? Tandaan nyo yun. May 4 hem siya. 1, 2, 3, 4. And each hem, yung pula na yan, iron yan. Each hem has 1 iron. So, in 1 hemoglobin, may 4 iron siya. 4 heme and 4 iron. So, for iron absorption, ayan. So, mainly, nangyayari to, na-absorb siya sa duodenum. Tandaan niyo, duodenum, important yan. Kahit sa ah, hematology niya, lalabas yan. Saan part ng intestines yung mainly na-absorb si iron? Duodenum. So for metabolisms, okay, so meron tayong ano, di ba nga sabi natin yung hemoglobin may iron. So pag, ano ba yung usual lifespan ng RBC? 120 days. So after nun, senescent RBCs na sila, madedegrade sila. Pupunta sa spleen, ayan, yung mga splenic macrophages, sisirain yung RBC, lalabas yung hemoglobin. So yung hemoglobin, madedegrade yan to heme. Yung heme may iron, so magiging free iron, tapos pwede ring ano, yung heme pwedeng ma-convert to bilirubin, di ba? Unconjugated muna. Yung free iron, pwede yan ma-recycle, pwede yung maging ferritin. Pag sinabing ferritin, yan yung storage form ng irons. Pwedeng maging hemosiderin, mga natatrap sa tissues, or pwedeng magamit ulit yung free iron and degrade sa RBCs, gawin ulit heme. Or pwedeng sa enzymes. Tapos ayan. Para makapag-travel siya plasma, kailangan nila ng transferrin. Yun yung parang bus ng iron. Tapos pabalik dyan. So yun yung iron metabolism. So yung major destination ng iron sa mga diet natin is through the storage sites. Yung ferritin, again, yan yung storage form ng iron. So ito, important din to. So iron from the diet is stored. Again, stored. Yung mga kinakain natin from meals, yung iron na nakukuha natin doon, stored lang yon. Anong ginagamit natin for hemoglobin synthesis? Para makapag-form ka heme. So yung iron, usually yung iron na nare-release sa senescent RBCs. So nire-recycle lang yung iron sa mga old RBCs natin na nasisira na. So ayan, stored iron or your ferritin is only consumed when the iron in the body is deficient. An example yan, IDA, iron deficiency anemia. Kaya di ba, isa sa unique dito, sa iron deficiency, mababa yung ferritin. Hindi lang yung sa iron levels mo sa plasma. Pero yung storage form, yung ferritin mababa. Ayun yun. Kasi, nakakonsume lang siya pag deficient ka na sa iron. Yeah. And take note, konti lang yung elimination ng iron natin, only to stools, bile, urine, sweat, or menstruation in females. And yung iron requirement for males, 1 milligram per day, or females, 1.2 milligram per day only. Ayan, tissue oxygenation. Di ba yung control ng RBC production, stimulated siya by hypoxia. Kulang ng oxygen sa tissues mo. So ano ba, pag may hypoxia ka, nasi-stimulate yung liver mo or specifically kidneys to secrete erythropoietin. Important yung erythropoietin kasi yung magsi-stimulate sa bone marrow mo ng RBC production. So it stimulates erythropoiesis. And again, tandaan nyo, erythropoietin is mostly secreted by the kidneys, 90%. Pero yung liver pwede rin, 10% lang. Pero important yung kidneys. So for example, may chronic kidney disease ka. Tapos nakita mo may anemia yung patient. Ano yung cause nun? Most likely dahil hindi nakapag-secrete yung patient ng erythropoietin. Kaya may anemia yung patients with chronic kidney disease. Again, important yan for erythropoiesis. And tandaan nyo, wait. So, kailan lang siya nasisikret? Again, pag may hypoxia. Decrease yung tissue oxygenation. Ito, tandaan nyo yung mga primary determinant. Yung oncotic pressure, primary determinant niya, plasma proteins, di ba? Specifically, anong plasma protein? Albumin. Yan, important yan. Oncotic pressure. Pag blood viscosity, RBCs. RBC production, tissue oxygenation. Okay, so we have this ABO blood group naman. Alam niyo na yung mga blood typing. Important din yan. So, di ba yung antigen? Yung type A, may A antigen, may B antibody. So, opposite lang. Yung type B mo, may B antigen, may anti-A naman. Type B, opposite. Pag type AB, so yung anong type, yun yung nagko-correspond sa antigen. Type AB, edi may type AB antigen, A antigen and B antigens. Pero walang antibody sa type AB. Pag type O naman, walang antigens, pero may anti-A and anti-B sila. And huwag kayong malito kasi May other terms yung antigen. Pag sinabi mong antigen, agglutinogen lang siya. Yun. Pare silang may gen. Gen, Gen. Agglutinogen, antigen. Same lang yan. Nasa surface ng RBC. Yung other name ng antibody, agglutinin. So, nasa plasma or serum lang yan nakikita. So, forward blood typing. Ito yung usually ginagamit para malaman yung blood type. So, ginagamit dito yung known anti-sera plus your blood sample. So, ganito yung reaction. For example, sa type AB. Yung known anti-sera, anti-A, anti-B. So, may agglutination. Yan yan. May mga clamping. Yan yung positive reaction. Agglutinating yan. So, meaning pag yung anti-A, mag-react lang yan sa A antigen. Yung anti-B, mag-react lang yan sa B antigen. So, pag nag-agglutinate yan, meaning may A antigen yan. Ito, nag-agglutinate din. So, may B antigen. Anong blood type yung may A and B antigen? Type AB. So, ganun lang yun. Yung forward blood type. Example again, type A. Again, agglutinogen is the same as your antigen. Ayan, anti-A. Diyan lang siya nagkaroon ng agglutination. Tapos type B, wala. So, yung anti-A nag-react lang sa A antigen. So, anong blood type yung may A antigen lang? Type A. Okay? Tandaan niyo yan. Pag walang agglutination, so walang anti-A, walang A antigen, walang B antigen. So, type O yun. Ito, cross-match. Tinatanong din to. So, we have the major and minor cross-match. Usually, ganito ko siya tinatandaan. So, for major, tandaan niyo, donors RBC and the recipient or the patient's serum or plasma. Ito yan, yung ginagamit ko. PSDR, patient's serum and donors RBC. So, dapat, pag major, dapat hindi mag-react. Pag hindi nag-react, meaning safe yan. We can transfuse the blood. So, mamaya, may example tayo dyan. Okay, so let's start answering questions for blood fissure. Which of the following does not belong in the group? Lymphocytes, platelet, red blood cells, monocytes. Para masagot mo to, you have to know lang yung lineages nila. Basically, lymphocyte. Kasi, nasa common lymphoid progenitor siya. Mga lymphocyte ito. Itong platelets, red blood cells, monocytes, ayan, dito yan. Ayan, platelets, your thrombocytes, RBC, monocytes. These are from a single common myeloid progenitor. What is the most predominant form of iron? Ayan. Yung major, most predominant, hindi siya ferritin. Kasi storage form lang siya, hindi rin transferrin, siya lang yung nagdadala ng iron or yung bus ng ano natin, ng iron. So the answer here is hemoglobin. Kasi di ba, your hemoglobin, may 4 na globin and may 4 na heme. And sa 4 hemes na yun, nandyan yung iron, ferrous iron. So yan yung predominant form ng iron sa RBC natin, sa hemoglobin. Ayan. So which donor-recipient combination is allowed for blood transfusion? So yung donor, type B, or yung recipient naman, AB positive. So para malaman natin, we will do major cross-matching. Again, yung PSDR. Ano yung PSDR? Patient serum, donors, red blood cell. Ayun lang. So, patient serum, patient o recipient. So, type AB siya. Ano yung nasa serum niya? Pag serum, antibodies lang. Pag type AB, may A and B antigen pero walang antibody. So, the patient's serum has no antibody. Tapos yung donor RBC, ito yung donor, type B. Ano ba yung nasa type B? Ano yung antigen? Anong nasa RBC? B antigen. So, walang antibody, pero may B antigen. So, walang reaction yan. So, safe. So, that's why that's the answer. Compare natin sa other choices. I-pick kung yung isa-isayin mo sila ng PSDR, major cross-match. Patient sa letter B. Ano yung patient serum dito? B negative. Patient serum, may B antigen pero may A antibody. So anti-A yung serum niya sa patient. Sa donor naman type A so may A antigen. Anti-A mag-react yan sa A antigen. So may reaction yan. So delikado. Kakaroon niya ng ABO incompatibility. So hindi pwede, not safe. Ganon din sa choice C. Yung patient natin, ano yung nasa serum? Patient serum. Walang antigen. Pero may A and B antibody. Ayan. Patient has A and B antibody. Compare sa donor na may A and B antigen ay mag-react talaga yan. So not safe din. So ganyan ako mag-cross match. Just know yung patient serum, donors RBC. So next question. We have a 25-year-old woman gave birth at home, rushed to the nearby municipal hospital, profuse bleeding. So ayan, so mababa yung hemoglobin, hematocrit, that's why blood transfusion was deemed necessary. Type B, yung patient, and na-transfusion ng 1 unit of type O blood. Alin dito yung true? Will a major reaction occur in the patient? No minor reaction, or she will suffer from a significant immediate blood transfusion reaction, or there will be another transfusion of type O blood that can be fatal. So the answer here is letter D. Again, kung i-cross-match natin siya. So yung cross-match again, yung major, PSDR, patient serum. Anong nasa serum ng patient natin? Type B siya. So may B antigen, may A antibody. Compared mo sa donor, type O blood, walang antigen. Donors RBC, walang antigen yung RBC nun. So safe yan. So dapat, major reaction will not occur. How about yung minor? Pag minor, baligtad lang. Patient's red blood cell naman compared to donor serum. So anong si patient? Red blood cell niya. So type B siya. So may B antigen yung red blood cell niya. Compared sa donor serum, yung type O, wala namang, yung serum nga, may ano yan, anti-A and anti-B. So may B antigen, mag-react yun sa anti-B ng donor serum. So may reaction yan. So dapat may minor reaction na mangyayari. She will suffer from significant immediate blood transfusion reaction. Hindi naman. Kasi nga, safe naman yung major cross-match siya. Wala namang mangyayari na immediate ABO incompatibility. Kasi safe naman sa major cross-match. Safe. Pero ito, another transfusion of type O blood in the future can be fatal. Yes, kasi anong problem dito? RH incompatibility. Pag RH negative ka, yung pwede lang sa'yo na blood, RH negative din. Hindi pwede ng RH positive blood. Kasi magkakaroon ka ng RH incompatibility. Pero delayed reaction to ha. Hindi siya immediate. That's why mali yung letter C. Hindi siya immediate, delayed siya. Pag nag-transfuse, kasi binobuo pa lang yung antibodies for against RH positive kasi dapat RH negative lang yung sa blood ng mga RH negative patients. Okay? So yung patient type B, yun yung meron siya. B antigen, anti-A, RH negative. Tapos binigyan mo ng type O positive. So safe naman sa major cross-match pero RH positive. Mag-react yan. So delayed transfusion reaction yung mangyayari sa patient pag RH incompatibility. So next, which of the following achieves the final state of hemostasis? Is it serotonin, thromboxane, thrombostatin, or factor 13, coagulation factor 13? So the answer here is your thrombostatin. Kasi for ano na to, clot retraction. Compared mo sa other choices ng serotonin, part pa rin siya ng primary hemostasis. Diba sa activation ng platelets. Thromboxane, yun din for ano, for aggregation. Primary hemostasis din yun. Ito, coagulation factors, secondary. Itong thrombostatin, after na yan ng clot formation, mag-retract na yung clot to decrease the wound. So yun yung final state ng hemostasis. Next question. So we have a 30-year-old pregnant who is diagnosed with preeclampsia. So, ayan, elevated blood pressure with proteinuria. Ayan. Madadaan niyo yan sa OB. With regard to the control of plasma volume, what can you conclude from this data? So, preeclampsia, mataas yung blood pressure and may proteinuria. So, more on sa ano to, mga Starling's forces yung affected. Is it more fluid from the interstitial space will be absorbed in the capillaries? Plasma will likely be filtered. Walang net movement ng plasma or edema will not occur. The answer is letter B. Plasma will likely be filtered kasi yung keyword mo dito, proteinuria. Iniihi mo yung plasma protein, specifically albumin. So, di-decrease yung albumin. Ano mangyayari pag nag-decrease yung albumin? Decrease yung oncotic pressure mo. Pag na-filter ng hydrostatic pressure, pag marireabsorb, hindi na marireabsorb kasi decrease na yung oncotic pressure mo. So, nagsistay siya sa interstitial fluid ito. Kung na-filter siya dito, nandito lang, hindi siya marireabsorb dito sa venial end. So, anong mangyayari? Tataas yung interstitial fluid mo. More filtration. Kasi less na yung oncotic pressure. Hindi na marireabsorbing na filter dito. So, that is more fluid. So, magkakaroon ng edema. Mag-accumulate yung fluid dito sa interstitial fluid. So, dapat edema will occur. There will be movement. Kasi more on filtration na. Kasi decrease na yung oncotic pressure mo. So, more fluid from the interstitial fluid will absorb into the cup. Hindi nga. Hindi na masyado na re-reabsorb. Mas nagsistay siya sa interstitial fluid. So, plasma will likely be filtered. Filter lang, wala na masyadong reabsorption kasi decrease na yung oncotic pressure mo. So, ito, madali lang. Blood components when centrifuge in a separate tube, where will the most dense portion of the blood settle? Basically, that's your lowermost. Ito. Kasi when you centrifuge your blood, nasa-separate siya into three components. Your plasma, your buffy coat, and your hematocrit, which is basically your red blood cells. And that's why ito yung pinaka-dense portion. Tandaan yung mga contents din. Plasma, syempre, nandito mga antibodies, waters, proteins. Buffy coat, nandito white blood cells, tsaka platelets. And yung lowermost, your hematocrit or RBCs. Ito naman, which dietary components is or are needed for DNA synthesis and thus greatly influence the production of red blood cells? Is it calcium? Parang hindi naman. Iron. Yung nasabi lang natin kanina, important yung iron, di ba, sa heme synthesis para maka-form ka ng hemoglobin. Di ba sa biochem nyo, may 8 steps ng heme synthesis. Yung last step doon is yung incorporation of iron into the protoporphyrin ring. So more on ano siya, hindi siya DNA synthesis. More on heme or hemoglobin. Vitamin B12 and folic acid, yes. So the answer here is C only. Hindi B and C ha. For heme synthesis lang to. Kasi itong vitamin B12 and folic acid, important yun for DNA synthesis and maturation of RBCs. Kasi di ba, pag nagkaroon ka ng vitamin B12 deficiency or folic acid deficiency, anong type of anemia yung nagkakaroon ka? Megaloblastic anemia. So dahil doon impaired yung DNA synthesis and hindi na nagmamature RBC kaya lumalaki yung RBC, megaloblastic yun. Again, hindi iron na hindi kasama kasi hemosynthesis lang. Hindi siya DNA synthesis. Okay, let's move on to immunity. So questions na agad tayo dito para mabilis. And medyo madali lang naman. So which is correct about the explanation of pag-organ transplant rejection? Is it when helper cells perforin cause water to gush inside the foreign cells? Helper cells ba yung may perforins? Hindi, di ba? Parang hindi naman. So B, when CD4 cells punch holes around the foreign organ? CD4 cells ba yung may function ng nagpa-punch holes? Parang hindi naman din. Or of course, when CD8 cells destroy the foreign organ. Ayun, pwede. Kasi yung CD8 mo, cytotoxic. Yung CD4, T helper cells lang yan. Or this occurs when suppressor cells have lost their normal function. Hindi naman. More on cancer mga to eh. So the answer here is letter C. Basically, yung A and B dapat CD8 ito. Siya yung may function ng may perforins and granzymes. Siya yung sumisira sa foreign organ. Characteristics of basophils. Dali lang to. Presence of granules, yes. Granulated yung mga basophils. Lasts for months in the tissues. Bacterial infection ba siya mataas? Di ba? Neutrophils dapat to, so hindi yan. Degrade bacteria, hindi naman. Neutrophils din yung may function yan. So the answer here is granules. Presence of granules in the cytoplasm. Ito. Which is an incorrect explanation about the cardinal signs of inflammation. Alin dito yung mali? Pag ba increase yung blood flow, increase yung interstitial hydrostatic pressure, therefore leading to edema. Tama ba yung binabasa nyo? Increase blood flow, increase interstitial. Interstitial ba? Or capillary hydrostatic pressure. Capillary yan. So mali yan. Ito lang nagpamali. B, blood cells tend to squeeze through the gaps, called diapedesis, pwede. An increase in filtration pressure due to vascular promote extravasation, correct. Blood vessels will reduce their laminar flow and lead to margination or pavement into vascular hole. Yes, tama. So yung mali lang is your letter A. Dapat capillary hydrostatic pressure yan hindi interstitial. Alam niyo yung mga different spaces sa mga image na pinakita ko kanina. Which is correct statement about passive immunization. So longer duration of protection ba? Passive immunization? Hindi, di ba? Kasi pag passive, shorter duration lang yan, pero immediate yung protection. Longer latency, hindi. Immediate nga yung immediate yung passive, immediate yung response. Higher anamnestic effect. When you say anamnestic effect, ito yung response. So, basically your memory cells. Pag na-infect ka, tapos sa second time na-infect ka ulit ng the same organism, mas mataas yung anamnestic effect mo kasi may memory cells ka na. Mas mabilis na yung response ng katawan mo pag second, pangalawang infection na sa same organism yung nangyari sa iyo. Yun yung ibig sabihin ng anamnestic. Basically, may memory ng katawan mo against that organism or pathogen. Provides immediate protection. Yan. Yun yung passive immunization. So these three are more on active immunization. Phagocytosis. Ano yung correct statement? Phagocytic vesicle is formed when the bacteria has engulfed into the white blood cell. Lipases are liberated by segmenters. Segmenters is your neutrophils, Lipases ba yung nire-release nila? Parang hindi naman. Digestive vesicles form when the Golgi apparatus fuses with the phagosome. Golgi ba? Parang hindi Golgi apparatus yan. Major basic proteins liberated by basophils? Hindi. Eosinophils yung may major basic proteins and for parasites yun. So the answer here is A. Ito hindi lipases, di ba yung mga MPO, may myeloperoxidase yung mga ginagamit ng neutrophils. Hindi lipases, kasi lipases more sa lipids lang yan. Dapat yung proteins ang sinasira nila ng neutrophils. Digestive vesicle, nafo-form siya pag yung hindi Golgi apparatus, lysosome. So yung lysosome, pag nag-combine siya sa phagosome, magiging phagolysosome, which is your digestive vesicle. Lysosome yan dapat. And again, eosinophils dapat ito. Okay, which scenario will cause an increase in basophil levels in your blood? Medyo madali lang to. Basophil, emphysema, 25-year-old rheumatic heart fever, 32-year-old house dust mite allergy, or yung may pulmonary TB. So the answer here is your letter C, yung may allergy, di ba? Your basophils and your mast cells more sa allergy sila. Tumataas. Okay, next we have a 32-year-old male was admitted in the hospital due to fever, absence of urine or anuria, body pain for 6 days duration. So 6 days na yung signs and symptoms niya. Pero diagnosed lang siya 3 days ago with leptospirosis. So bacterial infection yan from infected rodents. Which test results will be most reflective of his conditions? Okay, so medyo nakakalito to. Pero usually iniisip mo pag bacterial infection na na-diagnose ng leptospirosis, 6 days na yung onset ng signs and symptoms niya. So, usually, iniisip natin, IgM positive na yan. IgG negative kasi more after 1 week pa to usually na IgG. Depende. Pero the answer here is letter A. Yan, letter A, IgM negative and IgG. Hindi ko alam pero more on infectious disease question na to for medicine 3A. Kasi usually si Dr. Tanden, di ba yung sa immunity, yung nagla-lecture, siya rin yung mag-lecture sa infectious disease niya. So basically nakuha ko to sa Harrison's. Kung ito lang yung nakita kong that will help answer this question. Kasi leptospirosis. So tandaan niyo, pag leptospirosis, antibodies generally do not reach detectable levels until second week of illness. So ito, 6 days pa lang yung onset ng symptoms niya. 3 days pa lang diagnosed, pero 6 days na nagkakaroon ng symptoms. So, during 1 week pa lang siya. So, Hindi pa siya detectable levels. That's why IgM negative and IgG negative siya. Hindi ito. Common, nakakalito siya kasi more on infectious disease na to. Pero yun, that's why yung answer mo IgM negative, IgG. Specific to for leptospirosis. Okay, let's move on to electrophysiology and nerve physiology. Ayan. So we have the RMP, your resting membrane potential. Di ba? Yan yung steady potential. Tandaan nyo to. The RMP of your neurons is negative 70 millivolts. Pag skeletal muscles, negative 90 millivolts. Yan yung RMP ha. Pag sinabi mong threshold potential, yun yung minimum electrical activity para ma-initiate mo yung action potentials. So for neurons, negative 50 to negative 55. For muscles, negative 60 to negative 65. So example, yung resting state ng neurons mo, negative 70. May mga pumasok, may mga stimulus, may mga pumasok na ions, naging negative 55. Ayan, pwede na. Mag-i-initiate na yan. Na-reach yung threshold potential, pwede na mag-initiate, maging action potential. Yun. So yun yung threshold potential. And tandaan nyo itong mga local potentials. Di ba? Anong tawag natin sa local potential in skeletal muscles? End plate potential. Anong local potential in neurons? That's your postsynaptic potential. Yung postsynaptic potential divided into two. Pwedeng excitatory postsynaptic potential or inhibitory postsynaptic potential. Yan yung local potential. Yun yung mga names sila. Pag sa sensory receptors, that's your generator potential or receptor potential. Pag smooth muscles, ay may tatlo. Slow waves, basic electric rhythm, or pace setting potential. So action potential, ito naman yung stimulus na mag-change from RMP to threshold. So lahat naman ng cells, action potential lang yung tawag. Except sa smooth muscles. Yung tawag sa action potentials ng smooth muscles mo, spike potentials. Siya lang yung naiba. So tandaan nyo yun ha, yung mga namings nila. So ito yung mga parts ng action potentials. You have the resting membrane potential. Kasi pag na-reach na yung critical firing level or your threshold potential, ayun na, this is your depolarization. Hypopolarization or depolarization. Ito yung peak or yung overshoot. Dito na, repolarization na to. And here, after hyperpolarization yung tawag dito. Kasi open pa dito yung potassium channels. And para mabalik siya from hyperpolarized state to normal, sodium-potassium pumping responsible dyan. So ito, we have this, tandaan niyo itong mga gates ng action potential. Ay ng sodium, yes, your voltage-gated sodium channels. Yung activation gate, other name niya M gate. Inactivation gate, H gate. So at resting, ay naka-close lang yung activation gate pero laging open yung inactivation gate. Pag na-activate na, nag-depolarize na yung cell. So syempre, bubukas na yung activation gate para may sodium influx. Again, laging open naman yung inactivation gate. Nagko-close lang siya pag inactivated state na yan. Dito yan. Yeah. So para ma-relate nyo sa graph. So ito, sa RMP, resting state. Yan siya, yun yung normal state niya. Close yung activation gate. So walang makakapasok na sodium. Pero open lang palaging inactivation gate. Dito naman, sa nag-depolarizing cell. Ayan, bukas na yung activation gate. So papasok na sodium influx. Dito naman sa repolarization state, yung magko-close, yan lang yung time na magko-close na yung inactivation gate mo or your H gate. Diyan yan siya sa repolarization. So ang tawag dito, inactivated na yung sodium, your voltage-gated sodium channels. Kasi di ba may tinatawag tayong absolute refractory period. Ayan, dahil yan dito. Kasi inactivated na yung sodium channel mo. Naka-close yung inactivation gate. Kahit na open pa rin to. So wala pa rin makapasok na sodium. So kahit anong stimulus mo, hindi makakapasok yung sodium, hindi na excitable yung cell. So after ng repolarization, pag nakabalik na sa resting state, magiging normal ulit. Mag-open yung inactivation gate. Ito, important din to. Anong effects ng hypokalemia tapos hyperkalemia sa resting membrane potential? So you have your hypokalemia. So, pag hypokalemia, tingnan mo, ito yung normal. Pag, pag may hypokalemia, konti lang yung potassium nyo sa extracellular. So, anong tendency na, di ba may potassium leak channels naman sa mga cells? And di ba, sabi natin kanina, isa sa major intracellular sa loob ng cell is potassium. So, kung konti lang yung potassium sa labas ng cell, mataas yung tendency na lumabas na lang yung potassium from the cell to the outside. So pag lumabas yung potassium through the potassium leak channels, anong mangyayari sa loob ng cell? Nabawasan ng positive charge. Mas magiging negative. Ayan, hyperpolarization. Lumabas yung potassium mo eh. Nawalan ka ng positive charge. So mas naging negative, more negative. So dahil mas more negative ng RMP, ang hirap ng ito yung threshold potential, oh, ang layo na para magkaroon ng action potential. So ang hirap na niya i-excite. Kaya yung hypokalemia, less excitable. Pag hyperkalemia naman, sobrang taas ng extracellular potassium mo. Yung potassium mo sa blood, hyperkalemia. So ano mangyayari? Yung potassium leak channels, yung tendency, hindi nalalabas yung potassium mo kasi mataas na sa labas. Wala ng concentration gradient. So magsistay yung potassium sa loob ng cell mo in hyperkalemia. Pag nagstay yung positive ion, anong mangyayari? Mag-hypopolarize. Ayan, ito yung normal, ito na yung hyperkalemia mo. Malapit na sa threshold potential, so madali na siyang excite. Mas excitable na siya. Yun yung hyperkalemia, effects ng serum or plasma hyperkalemia. More excitable pag hyperkalemia, less excitable pag hypokalemia. So, yeah, let's start answering questions for this one. So pertaining to membrane potentials, which of the following properties is true? Local potentials exhibit hypopolarization and graded response. Yes, pwede. Graded response ng local potential. Resting membrane is created mainly by high sodium conductance. Sodium pa, yung responsible for RMP. Di ba potassium? So mali yan. Potassium yung responsible sa RMP, or resting state, kasi may potassium leak channels tayo. Or adequate stimuli summate to generate progressively increasing magnitude of action potentials. Tumataas ba yung magnitude na action potentials? Hindi. Pag action potentials, all or none lang yan. Same magnitude, hindi tataas yung magnitude. So dapat local potentials yung increasing magnitude. So mali to. Inactivation gates of sodium channels are close at resting membrane potentials. Kapag RMP, di ba sabi natin, yung inactivation gate, open lagi. Nasaan yun? Balikan natin. Ito yung inactivation gate. So open siya palagi. Nag-close lang siya pag repolarization na dito. Pag nag-repolarize yung cell, dun lang siya mag-close. So the answer here is letter A. Yun yung local potentials may hypopolarization or graded response. Dapat potassium to, dapat local potentials to, dito naman are open dapat. Inactivation gates are open at resting membrane state. So next, a 34-year-old male brought to the ER due to lockjaw and spastic paralysis. So may tetanus infection. So ano yung dinedegrade ba ng tetanus plasmid? Tetanus. Is it snare proteins, kinesin-dynein, tropomyosin complex, myelin sheath? Best answer here is your snare proteins. Di nalagay, pero snare proteins yan. So basically, tandaan nyo to. Medyo laging may nalilito dito, no? Tandaan niyo pag tetanus infection, CNS yan, spinal cord. Pag botulinum, peripheral nervous system yan. Spastic ito flaccid. Kasi ano ba yung ginagawa ng tetanus? Kiniklib niya yung snare protein, specifically yung synaptobrevin. Di ba sa action potential sa neuron? After magkaroon ng action potential, dito na sa axon terminal, mag-open yung voltage-gated calcium channels. Papasok yung calcium. Calcium binds to your synaptotagmin. Tapos madadala yung mga vesicles, madadala to your periphery. So, mag-i-interact na doon yung mga snare proteins mo. Ayan, your synaptobrevin, syntaxin, SNAP25, mag-i-interact na yan, leading to exocytosis. So, yung sinisira ng tetanus toxin mo, yung synaptobrevin, ayan. Ito yung sinisira niya. So, nangyayari to again sa CNS spinal cord. Mostly sa mga GABAergic neurons or glycinergic neurons. So, pag ganon, sinira mo yung snare proteins. Pag pumasok yung calcium, ah, magmo-move yung vesicles from center to periphery. Pero hindi na magkakaroon ng exocytosis kasi sinira na yung mga snare proteins mo na important yan para exocytose yung laman ng vesicles. So, sabi natin, nangyayari ito sa GABAergic neurons and glycinergic neurons. Di ba yung GABA, major inhibitory neurons yan? Inhibitory din yung glycine. So, pag hindi mo na i-exocytose, hindi lumalabas yung GABA mo, walang inhibitory signals to your motor neurons. So, pag may stimulus, nag-contract yung motor neurons mo, nag-contract yung muscle, wala nang wala nang regulation by your upper motor neuron. So, walang inhibitory, hindi ma-release yung GABA. So, laging excited yung motor neuron. That's why it leads to spastic paralysis. Tetanus yun, ha? Pag botulinum, ganun din. Sinisira niya rin snare proteins. Yes, pare sila sinisira ang snare proteins. Pero bakit ito flaccid pag botulinum? Kasi, nangyayari ito sa neuromuscular junction sa motor, ayun na, neuromuscular junction. Peripheral na. So, yung ginagawa dito, hindi na it's more on sa ACH or acetylcholine. Di ba kailangan mo ng acetylcholine para mag-bind sa nicotinic receptors para magkaroon ng muscle contraction. Pag botulinum, sinisira ng snare proteins, hindi mo may exocytose, hindi lalabas yung acetylcholine. Wala kang muscle contraction, kaya flaccid paralysis pag botulinum. Again, pag tetanus, spastic. Kaya may lockjaw yung patient. Ito, IPSP, inhibitory postsynaptic potential. Diba, local potential yan in neurons generated by increased potassium conductance. Pag, pag-increase yung potassium conductance, lumalabas yung potassium. Kasi may potassium leak channels and major intracellular siya. So pag lumabas ba, inhibitory, increased calcium conductance, hindi siya inhibitory. Kasi pag pumasok yung calcium sa cell, edi magde-depolarize siya. Same with increased sodium channels. Pag mas maraming sodium channels, mas maraming pwedeng pumasok na sodium. Or decreased potassium conductance, magsistay lang siya sa loob yung potassium. Pag nagstay lang sa loob yung potassium, edi mas madali siya ma-excite. So, hindi siya inhibitory. So, the answer here is letter A, increased potassium conductance. Again, ito. RMP, ito yung inhibitory postsynaptic potential. Mas naging hyperpolarized kasi lumabas yung potassium. Pag lumabas yung potassium, nawalan ka ng positive ion sa cell. Adi mas magiging negative yung cell. Ayan, inhibitory postsynaptic. So again, yan yung local potential sa neurons. Increased potassium conductance. Hindi to. Pag decreased potassium conductance, nagsistay lang yung potassium sa loob ng cell, excitatory yun. So during relative refractory period, ayan, relative time, action potential, excitability is, di ba yung refractory period natin may absolute tsaka relative. Pag absolute, hindi mo talaga siya masistimulate kahit anong gawin mo, kahit anong stimulus. Pag relative, pwede siya mastimulate pero dapat higher yung stimulus. Supra-threshold. Above the threshold yung stimulus dapat. So, decreased ba yung excitability due to hyperpolarization, increase due to opening of all sodium channels, decrease due to the activity of sodium-potassium pump, or increase due to excitatory postsynaptic potential. So the answer dyan is decrease due to hyperpolarization. Ito yung refractory periods. Action potential, ayan. Ito na, yung repolarization period. So, itong pink area na to, yan yung absolute. Hindi mo pwedeng ma-stimulate ulit yung cell kahit anong stimulus yung ibigay mo. Dito sa relative refractory period, pwede pa. Higher na stimulus lang yung kailangan. So, yan, may decrease yung excitability ng cell in this area kasi ito yung area na may after hyperpolarization. So, decrease siya due to hyperpolarization. So when a cell is polarized, or pag sinabi mong cell is polarized, yan yung resting state. These conditions are observed in voltage-gated channels. Yung voltage-gated sodium channels are closed by their activation gates. Pag resting ba, anong naalala nyo kanina? Yung sodium channels? Yes, yung activation gates closed. Yung laging open, inactivation gates. So pwede. The voltage-gated potassium channels are closed by their inactivation gates. See, activation gates, inactivation gates are both closed? Hindi. Di ba laging open yung inactivation gates, sabi ko. Both sodium and potassium have closed activation gates. Yes, the answer here is letter D. Para sila closed. Ito yung potassium channels. Compared sa voltage-gated sodium channels, may activation gate siya and may inactivation. Pero pag potassium channels, activation gate lang siya. So, syempre, pag resting state, closed yan parehas. Di ba nag-open lang yung voltage-gated sodium dito pag nag-depolarize. Nag-open lang yung voltage-gated potassium channels pag nag-repolarize na dito ang area. So, that's why ito yung correct answer. Ito naman, when an excitable cell is affected by several subthreshold stimuli, simultaneously, this could happen. So simultaneously, electrical activity of membrane could reach the threshold voltage, cell could inactivate the voltage-gated sodium channels, the cell generates only a local depolarizing change, or the cell immediately opens. The voltage hindi naman ganyan. So the answer here is letter A. Yes. So kasi pag several sub-threshold or your local potential simultaneously, so magsasummate siya. So pag nag-summate yun, ito, for example, one stimulus, tapos another one, nag-summate yung dalawa, ang stimulus, marireach yung threshold potential. Depolarize. So, di ba sa summation, for nerves, sa summation, meron tayong temporal summation and spatial summation. Pag sinabi mong temporal, successive yan. Sunod-sunod. So, dito sa example sa taas, simultaneous, spatial summation yan. Pag sunod-sunod ito, isa muna na stimulus, tapos isa ulit bago magbalik sa RMP. So, dahil dyan nag-summate, nag-add together sila, na-reach na yung threshold. Pares yung local potential pero na-reach yung threshold. Depolarize na. Or yung spatial summation, sabay-sabay. Ayan. One stimulus plus another stimulus, sabay sila nag-act sa cell. Hindi nag-summate sila. Mas mataas yung stimulus. Mas mataas yung magnitude ng local potential, marireach yung threshold. Yun yung, tandaan nyo yan ha, temporal and spatial summation yung pinagkaiba nila. Pag temporal, sunod-sunod, yan, another one, tapos ayan. Pag spatial, sabay-sabay, simultaneously. Example, dalawa. Sabay sila nag-release ng neurotransmitters. So, mas may exciting postsynaptic. At the peak of depolarization, these conditions are observed. Voltage-gated sodium channels are closed by activation gates. Sa peak na ng depolarization magko-close ba yung activation gate? Hindi, di ba? Hindi nagko-close lang sa pag nasa peak na ng depolarization, inactivation gates yung nagko-close. Voltage-gated potassium channels, yes. Mag-open na yung voltage-gated potassium para mag-efflux. Potassium efflux for repolarization. Magsa-start na yan. Inactivation gates of voltage-gated sodium channels are about to open. Inactivation, magko-close na dapat yung inactivation gates. Hindi open. Potassium ion starts to move inward. Ay, hindi ba nasa loob, major intracellular na yung potassium? So, bakit siya magpapasok inward? So, dapat outward yan. Efflux. Potassium efflux. So, the answer here is voltage-gated potassium channels open. Kasi nasa peak na for repolarization. Ito, when a cell is inactive or polarized, o nasa resting state, sodium-potassium pump is inhibited? Ay, hindi. Active yan lagi, yung sodium-potassium pump. Even in inactive or polarized. So, mali ito. Sodium-potassium leak channels transfer potassium ions in and sodium out. Membrane has a greater conductance to sodium ions, or membrane has greater conductance to chloride ions. So the answer here is letter D. Yes, may chloride ions din na pumapasok sa cell. Kasi di ba yung chloride, major extracellular din yan. So, yes, may conductance yung chloride ions. Again, hindi pwede to. Sodium, potassium, leak channels. Di ba yung potassium ions in sodium out? Sodium, potassium pump yan. Hindi siya leak channels, So, mali yan. Membrane has greater conduct. Ay, hindi. Hindi mataas yung conductance sa sodium. Sa potassium yung mataas yung conductance. So if there's a problem where your presynaptic region is not capable of producing synaptotagmin, there will be inability of vesicles to move towards a presynaptic membrane, inability of the presynaptic area to produce a neurotransmitter agent, excessive release of neurotransmitter agent towards the synaptic cleft, or increased sensitivity of the presynaptic nerve. So hindi siya capable. Pag may not capable of producing synaptotagmin, the answer is letter A. Kasi di ba, again, yung flow mo ng action potential at the axon terminal. Kung may action potential na sa axon, sa hillock, magta-travel siya hanggang sa axon terminal, and yun mag-opening voltage-gated calcium channels. Calcium influx, then yung calcium magbabind sa synaptotagmin. Tapos, pag nag-bind yun, mag-move na yung vesicles from center to periphery, and then, mag-i-interact na yung mga snare proteins leading to exocytosis. So, kung walang synaptotagmin, anong gagawin ng calcium after ng calcium influx? Wala. Hindi siya walang movement. So, inability of the vesicle to move towards the presynaptic membrane. Ito yung presynaptic membrane. Nasa center lang siya, hindi siya makapunta sa periphery, yung mga vesicles. Kasi walang synaptotagmin. So, tandaan nyo yung synaptotagmin, dyan nagbabind yung calcium. Or actually, calcium sensor siya. Okay, let's move on naman to muscle physiology. Ayan, important to. Dapat alam niyo yung mga terms. Batmotrophic means increase yung excitability. Dromotropic, conductivity yan. More on conduction. Inotropic, more on contraction ng heart. Chronotropic, ayan, may HR sa chrono. So, heart rate yun. So, tandaan yung mga types of muscle, yung mga itong properties sila. Usually, tinatanong din yan. Mag-skeletal, long cylindrical, multinucleated, cardiac, cylindrical, branch, or mononucleated. Ito, cylindrical, diba? Tapos, branch. Branch yung cardiac myocytes na. Smooth muscles, ayan. Yung voluntary lang, skeletal muscles, syempre, involuntary na itong dalawa. So, ito yung organization ng skeletal muscles mo. So, from the muscle, epimysium, covered siya ng epimysium. Yung whole skeletal muscle, epimysium. Tapos, going to the fascicles, ayan. Yung fascicles, covered yan by your perimysium. Ayan yung perimysium. Covered yung fascicle. Tapos, yung muscle fiber naman, ito, covered siya by endomysium. So, epi, peri, endomysium. Tapos, after the muscle fiber, myofibrils. Ayan, containing the sarcomere, yung functional unit. So, we have here the neuromuscular junction. Ayan. Di ba? From the motor neuron to the skeletal muscle. Neuromuscular junction. So, yung acetylcholine, magbabind yan. Pag na-exocytose na, magbabind yung ACH, nicotinic 1 receptor sa motor end plate. Tandaan niya, ACH, pag skeletal muscles, nicotinic 1. So, magkakaroon niya ng entry of cations. So, syempre, mag-hypopolarize, pero end plate potential pa lang yun. Local potential, di ba? Yan yung tawag sa local potential in your skeletal muscles, end plate potential. So, hindi pa siya action potential. Pero as more acetylcholine binds to the nicotinic 1 receptors, tataas yung hypopolarization, magsasamate, end plate potential sa mates, ma-reach na yung threshold, dun pa lang siya magde-depolarize. So ito, pag nag-depolarize na yung motor end plate mo, ito yung sarcolemma. Nag-depolarize din dito, may mga butas dyan. Ito yung T-tubule mo. Yung mga butas na yan, T-tubules yan. Ayan. Di ba may tinatawag tayong triad dito? This is your T-tubules, tapos sandwich siya by your two terminal cisterns. One terminal cistern, one terminal cistern ng sarcoplasmic reticulum. So yun yung triad composed na T-tubules. So looking at it in another perspective, ito yung T-tubules dito sa graph. So di ba na-excite na natin? May action potential na sa sarcolemma. Nag-depolarize ng skeletal muscle. So tatravel yung action potential dito sa T-tubules. Yan, papasok yan dyan. Papasok sa T-tubules, and dito sa T-tubules, nandito yung dihydropyridine receptors mo or your ryanodine receptors. So, ating dihydropyridine, ito muna yung ma-activate. So, voltage-gated calcium channel siya. So, yung action potential travels to the T-tubule, activates your dihydropyridine receptor, which is a tandaan nyo to, yung dihydropyridine voltage-gated calcium channels. Yung ryanodine, mechanically gated calcium channels. So, action potential travels, na-activate mo yung dihydropyridine, mag-i-interact ngayon yung dihydropyridine sa ryanodine receptors, opening the calcium channel, yung ryanodine receptor. So, yung, di ba concentrated, ito yung sarcoplasmic reticulum. Di ba modified smooth endoplasmic reticulum? Ito yung nasabi natin sa cell physiology. Di ba may function siya na calcium sequestration. Ito yung modified smooth endoplasmic reticulum, sarcoplasmic reticulum yan sa skeletal muscles. So definitely, mataas yung calcium dyan. So pag nabukas yung ryanodine receptors, ginalaw ng dihydropyridine, ayan, mag-exit na yung calcium going to the sarcoplasm. Ayan, pupunta na yung calcium to your sarcoplasm. So, meron din tayong thin filaments sa thick filaments, di ba? Kasi yung need nyo tandaan sa thin filaments. Ito yung thin filaments. Ito yung mga bilog na yan yung actin. Tapos itong mga black sa actin, yan yung myosin binding sites. Diyan magbabind yung myosin para magkaroon ng, di ba sa sliding filament theory, may power stroke. So dito magbabind, pero nakikita niyo may tropomyosin na kino-cover. Covered yung myosin binding site. So hindi makakabind. So di ba anong sabi natin dito? So nag-opening ryanodine receptors, lumabas yung calcium. Ayun, yung calcium, mag-i-interact na siya sa mga troponin complex, specifically troponin C. Tandaan yun, troponin C where calcium binds. Yung mangyayari ngayon, yung troponin C, pag nag-bind yung calcium dyan, yung tropomyosin, magkakaroon ng mga processes na yung tropomyosin would move away. Ayan o. Tingnan mo. Nag-move away, nag-conformational change, na-expose na yung myosin binding sites. So, ready na. Pwede na mag-bind yung myosin. So, kailan lang siya na-activate? Kailan lang siya nagiging ganyan, na-expose yung binding site? Pag nag-bind na yung calcium. Tandaan yung mga functions nila. Yung mga iba na nag-anchor, alpha-actinin, capsaicin protein, etc. So, ayun. Let's talk about the sliding filament theory muna. Ang other names niya, walk-along theory or the cross-bridge cycle. So again, na-release na natin yung calcium from sarcoplasmic reticulum. Pumunta na sa sarcoplasm. Ngayon, yung calcium magbabind na sa troponin C para ma-expose yung myosin binding sites. Ayan, no? Expose na. So may calcium na dyan. Ito yung myosin mo. Ito yung actin or thin filaments. Ito yung myosin, your thick filaments. Di ba yung myosin, dalawa yung heads? One for isang ATPase and one yung magbabind dito. Yung isang head, laging may yan. May nakabind na ADP and organic phosphate. Ina-hydrolyze yung ATP to become ADP and organic phosphate. So pag na-expose yung binding site, ma-attract yung myosin head, yung isang myosin head na mag-bind doon. So pag nag-bind doon, yung ADP, i-release na niya. I-release yung ADP and inorganic phosphate. Pag ni-release na niya, ayan, mag-move na yung head. Ayan. From cocked position to ganyan. Minove na niya toward the center of the sarcomere. So yan yung power stroke. Pag movement ng head. Pag ni-release na yung ADP and organic phosphate. Pero tingnan nyo, nakabind pa rin yung myosin kailan lang siya marirelease? So, pag may nag-bind na ATP, dun lang siya marirelease. Ayan. Pag nakabind ng ATP sa myosin, dun lang siya marirelease. Tapos, i-hydrolyze na yun ng isang myosin head yung ATP, magiging ADP inorganic phosphate ulit yung ATP, tapos magiging from ganitong position, magiging cock position ulit, meaning energized state na yun, cock position. Ganyan ulit. So, the cycle continues hanggang mag-shorten yung muscle or yung sarcomere. Ayan. Other pictures lang. So, during power stroke, pag nirelease ng ADP in organic phosphate, yun na, mag-move na yung power stroke. So, pero nakadikit pa rin siya. Kailan lang madedetach yung myosin head? Pag may nag-bind na ATP. Ayan, ito ang summary. Pag may yung myosin, may ATP inorganic phosphate, yung PI, inorganic phosphate yan. Nasa resting state lang siya or cock position. So, mataas yung energy niyan, cock position. Pag nirelease niya yung ADP, yun na, power stroke or other name, Rashett action. Myosin, pag nag-bind ng ATP, dun lang siya magde-detach. So, tandaan niyo yan. Tinatanong yan. So, yun yung, let's now talk about since pag-usapan na natin yung mga nangyayari, molecular. So, let's start na sa excitation, contraction, coupling. Tandaan niyo, nagsa-start siya pag may action potential na sa sarcolemma, and yung end lang niya pag nag-shortening sarcomere or muscle contraction. Hindi kasama yung muscle relaxation. So we have the motor end plate, nag-depolarize, ayan. Action potential, again, mag-reach sa T-tubules and nandun sa T-tubules yung dihydropyridine receptor, ma-activate yan, mag-i-interact yung dihydropyridine to ryanodine. So, ma-release na yung calcium from the terminal cisterns of the sarcoplasmic reticulum to the sarcoplasm, and yung calcium na na-release, magbabind na sa troponin C. Pag nangyari yon, tropomyosin moves and may exposing myosin binding sites sa actin. Tapos yung myosin, magbabind na sa actin. Iyan na. Pag nag-binding myosin sa actin, you call that cross-bridge formation. So eventually, mag-lead to power stroke pag release ng ADP and inorganic phosphate, and it moves the actin towards the center of the sarcomere, leading to muscle contraction. So yan yung excitation, contraction, coupling. So anong relaxation phase naman? So this is when the ATP, di ba yung ATP na hydrolyzes to ADP and inorganic phosphate? Ayan. Pag nag-accumulate yung ADP tsaka inorganic phosphate plus other acidic molecules, hydrogen ions, lactic acid, lahat yan acidic, malalower yung pH sa sarcoplasm. Ano naman kung nalower yung pH? Di ba pag lower pH, acidic yan. Pag nalower na yung pH yun, nalolower yung calcium affinity to troponin C. Di ba dyan sa troponin C nagbabayad ng calcium? Eh pag acidic na yung sarcoplasm, kasi nag-accumulate na yung inorganic phosphate, hydrogen ion, lactic acid, aalis na, madedetach na yung calcium from the troponin C. Tapos yung calcium, ibabalik na ni Circa. Diba uniport ito? Circa, papump nila tapos active prime, kailangan na ng ATP. Babalik na niya yung calcium to the sarcoplasmic reticulum. Yun yung role ni Circa, babalikin sa sarcoplasmic reticulum to sequester yung calcium ulit. So important yan ha. Ito actually yung concept ng muscle fatigue. Kung masyado ng siging contract ng skeletal muscles mo, nag-accumulate ng mga lactic acid, nag-anaerobic respiration na. Yun, nag-accumulate na yun. Hindi na makakontract yung muscle mo kasi kahit na gustong pa i-contract kasi sobrang acidic na ng sarcoplasm. Hindi na makabind yung calcium sa troponin C kahit madaming calcium kasi sobrang acidic na ng sarcoplasm or environment ng skeletal muscles. Kaya hindi na mahirap na magkaroon ng muscle contraction. Yan yung concept ng muscle fatigue. Summation naman ng skeletal muscles. Diba meron tayong quantal summation and frequency summation. When say quantal, ito yung application of increasing intensity at a certain interval. Hindi siya continuous. And the principle here is recruitment or size principle. So yung mga maliliit mo na skeletal muscles hanggang sa ma-recruit mo yung larger skeletal muscles, pag na-recruit mo na yun, mas tataas yung intensity, syempre. Frequency summation, basically, nasa name na, application lang ng same intensity, pero increasing frequency. Same intensity lang, pero tinataas mo lang yung frequency. Okay, so let's start answering questions for muscle tissue. Which of the following elicits frequency summation? Successive stimulation of the nerve with an increasing intensity, frequency summation. Successive stimulation nerve with sub-threshold intensity, di ba? Pag sinabi mong frequency summation, same intensity pero increasing frequency lang. So, hindi nag-i-increase yung intensity. Mali ito. Ito pwede pa. Sub-threshold intensity, simultaneous arrival of several stimuli at the nerve, or simultaneous blocking of stimulatory basis of muscle contraction. So, the answer here is letter B. How about here? Correct statement about the molecular basis of muscle contraction. Ayan. Di ba, other name, di ba, ng sliding filament theory, Walker-Long theory. So, this theory occurs when a series of power stroke will pull on the myosin filament. Myosin ba yung pinupull? Di ba, yung myosin yung nagbabind sa actin para i-pull yung actin towards the center. So, hindi myosin, ha? So, hindi yan. Letter B, the head of the myosin binds with the thick filaments active site to cause uncocking of the head leading to power stroke. Binding of ATP to the myosin head will cause it to detach if more work is desired. Or letter D, FENFX states that the lesser ATP will be cleaved if more work is desired. So the answer here is letter C. Anong nagmamali sa B? Hindi siya thick film. The head of the myosin binds with the thin filament. Nasa thin filament or your actin. Actin, thin filament. Nasa name na actin. Thin filament yon. So nandun yung myosin binding sites, hindi sa thick filament. Kasi yung myosin, yan yung thick filament. So mali yan. So dapat binds with the thin filament's active site, causing the uncocking of the leading to power stroke. Ito yung tama. Binding of ATP to the myosin head will cause it to detach if more work is desired. Yes. Ito diba sabi ko? Diba yung myosin naka-attach lang siya sa binding site ng actin. Kailan lang siya matidetach? Pag nag-bind na yung ATP sa myosin. Yun lang siya matidetach. Itong FENFX, sinasabi lang dito na greater use of muscle, the greater heat will be produced. So dapat, greater ATP will be cleaved if more was desired. Yun yung nagpamali dyan. So which is a correct statement about neuromuscular junction? Golgi apparatus in the soma will manufacture the vesicles which eventually contain norepinephrine. Nasa ano tayo ha? Take note, neuromuscular junction. May norepinephrine ba doon? Di ba ACH mostly yung neurotransmitter agent doon? So hindi norepinephrine. The release of ACH from the postsynaptic terminal. Postsynaptic ba na-release? Via exocytosis. Di ba presynaptic dapat? To the postsynaptic. Yun ang part. So our destruction of ACH by an esterase found in the synaptic cleft. Pwede. Ano ba itong esterase? Acetylcholinesterase. Yan. Siya di ba yung sumisira sa ACH? And yes, nasa synaptic cleft yun. Ready to degrade ACH after mag-bind sa nicotinic receptors. Binding of ACH to the muscarinic receptors will cause local excitatory signal called the end plate potential. Muscarinic receptors ba yung nagbabind? Hindi, di ba? Dapat nicotinic receptors. ACH and nicotine kasi we are at the neuromuscular junction. So the answer here is letter C. Esterase, basically yan yung acetylcholinesterase na sinisirang ACH. So next, which of the following is a true statement about the excitation of skeletal muscles? Once the impulse travels down the transverse tubules or your T-tubules, mechanically gated dihydropyridine receptors. Mechanically gated ba yung dihydropyridine receptors? Di ba voltage gated yan? Will open, leading to the opening of chemically gated o yung ryanodine receptors din. Mechanically gated yan. So hindi. So dapat voltage to, ito, mechanical. In humans, so mali to. In humans, there are 2 sarcoplasmic reticulum and 1 transverse tubule in a triad. O yan. Diba na-mention natin ito kanina? Yung triad consists of your T-tubule sandwiched siya by your 2 terminal cisterns of your sarcoplasmic reticulum. So, correct. Letter B, correct. Or C, calcium released by the tubule will increase the cytosolic calcium level inside the muscle cell. Hindi. Hindi nire-release ng transverse tubule yung calcium. Sa sarcoplasm lang by your sarcoplasmic reticulum, nag-release ng calcium. Kasi siya yung modified smooth endoplasmic reticulum na may calcium sequestration function. Next, which are correct statements about the mechanical properties of skeletal muscles? Trepe, the warming up effect can be due to the accumulation of cytosolic calcium ions, leading to higher work output. Tetanus occurs when the skeletal muscles will be continuously stimulated during the entire phase of a simple muscle twitch. Yung tetanus, basically, yan yung mataas na muscle contraction. Hindi siya simple. Size principle states that smaller muscle will be stimulated first before the larger fibers since the former are prone to fatigue. Tama naman to, pero yung former, hindi siya prone to fatigue. Yung larger muscle fibers yung prone to fatigue kasi mas malaki. So the answer here is letter A. Basically, yung Trepezian staircase phenomenon. Next, which will best describe the skeletal muscle of a 42 kilometer marathoner? Ayan, dapat alam niyo yung mga types of skeletal muscle. Rich in glycogen, rich in myoglobin, predominantly white ba, predominantly type 2 fibers. So, ito yan. So, tandaan niyo itong table. So, the answer here is rich in myoglobin. Because we have the type 1 and type 2 muscles, no? Yung type 1 slow oxidative, color red yan. Slow oxidative, kasi slow yung myosin ATPase rate niya. So meaning mabagal siya mag-hydrolyze ng ATP to ADP in inorganic phosphate. So kung mabagal, konti lang yung nag-accumulate na inorganic phosphate, making it hindi masyadong mag-accumulate in organic phosphate, less acidic. So pag less acidic, di ba, hindi masyado nagiging acidic yung environment ng sarcoplasm, edi mas makakabind pa yung calcium to troponin C. Kaya siya fatigue resistant. Mabagal siya mag-accumulate. And because slow siya, hindi na kailangan ng mabilis na ATP. So okay lang siya na aerobic respiration. Yung oxidative capacity niya high. Mataas yung mitochondrial content, capillary density, myoglobin. Pag mataas yung myoglobin, yun yung red pigment din, making it red. Kaya yung type 1 red, no? Slow oxidative red. Yung glycolytic capacity moderate lang kasi yung glycolysis more on anaerobic. Pag slow type 1, more on aerobic na din to kasi mabagal naman yung ATPase rate niya. So more on yung function ng anti-gravity with bearing and sustain. So maganda siya for long endurance. Kaya pag marathoners, more on endurance yan. Ito yung type 1. And nandito yung type 1 rich in myoglobin kasi red. Ayan o. Yung oxidative high. Yun yung myoglobin content. Kasama dyan. High. Yung iba hindi. Yung tatandaan nyo na isa yung type 2B. Fast glycolytic. More on burst power to. Ito yung type 2B more on gym. Yung nagdi-gym peoples. So yan yung dahil dito more on anaerobic yung type 2B glycolytic. Wala masyad, ayan, low lang yung oxidative capacity, konti lang yung myoglobin kaya white. Dito mataas yung myoglobin kaya red. And dahil dyan, more on anaerobic respiration to. Kaya mataas yung glycolysis dito, glycolytic capacity. Para may immediate ATP from glycolysis. Kasi di ba pag aerobic, kailangan pa magdaan sa electron transport chain, yung Krebs cycle, so matagal yun. Pag dito, glycolysis lang. Pero yung pag mga type 2B, ano siya, fatigue prone. Yun ang tatandaan. Pag type 1 din, fatigue resistant siya. Ito, maganda siya for fast burst power, mga gym, pero mabilis na pagod. Ito, endurance yung type 1. So next, which statement best describes a patient with tetanus infection? Na-mention natin to kanina, yung about tetanus and botulinum. Weakness ba is due to the inhibition of glutamate in spinal cord? Ano ba yung glutamate? Excitatory ba yan or inhibitory? Di ba excitatory yan? So hindi glutamate. Inability of the vesicles to duct into the axon terminal. Weakness is mainly due to flaccid. Flaccid ba yung tetanus? Di ba may lockjaw dyan? So spastic dapat kasi yung problem sa tetanus, sinisira yung snare proteins. Hindi marirelease, hindi magkakaroon ng exocytosis kasi wala kang snare proteins. Sinira ng tetanus toxin sa mga GABAergic neurons and glycinergic neurons. So, hindi marirelease yung GABA, hindi marirelease yung glycine. So, anong mangyayari doon? Hindi regulated yung motor neuron. Laging pag nag-contract yung muscle, mag-contract and contract pa rin yan. Hindi siya, walang inhibitory. Walang nare-release na GABA, kaya spastic pag tetanus. Pag flaccidity, botulinum. Hindi mo makakontract yung muscle mo. Inability of the muscles to relax due to the inhibition of an inhibitory neurotransmitter agent. Yes, again, ito yung tandaan nyo. Hindi makaka-relax yung muscle kasi inhibited yung GABA or glycine, which is an inhibitory neurotransmitter agent. So inhibited siya ma-release. Hindi makaka-relax yung muscle mo. That's why it's spastic paralysis for tetanus. For botulinum, it's flaccid, more on peripheral nervous system. Next, which is a correct statement about the functional organization of skeletal muscles. So we have the epimysium around the muscle fibers. Muscle fibers ba? Epimysium. The myosin is made up of multiple G-actin molecules, yung mga bilog-bilog. Myosin ba yun? Di ba actin yung may mga bilog-bilog? Troponins are found attached to the thick filament. Yung troponins ba? Yung mga troponin C, troponin I, nasa thick filament ba yun or nasa myosin? Hindi, nasa thin filament, di ba? Or your actin. The myofibril contains the basic contractile unit. Yes. Epimysium yung nag-wrap around the whole muscle cell. No? Pag muscle fibers, endomysium yun. The answer ito. Yes, your myofibril, andyan yung basic contractile unit which is your sarcomere. Okay, let's move on naman to autonomics. Ayan. Tandaan nyo, ito marami pa rin dito nalilito. So your nervous system, pwede siyang CNS. Anong nasa CNS? Spinal cord, your brain. Silang dalawa. Pag peripheral nervous system, compose yun yung cranial nerves and spinal nerves. Pero yung peripheral, further divided into your somatic, which is for voluntary skeletal muscles, or your autonomic nervous system. So, ayan. Yung autonomic nervous system mo, usually, depende sa source, pero usually it's three. Your parasympathetic, sympathetic, and even your enteric nervous system. Parasympathetic, rest and digest, sympathetic, yung active. Ito, tandaan nyo. Ito important to. Dapat na-master nyo to para mas maintindihan nyo, di ba, yung sa pharma nyo. So, let's go agad to the samples. Sample questions na. So, sympathetic nerves to the small intestine originate from and synapse with a blank ganglion. So, the answer here, ano ba yung sympathetic? Di ba yung sympathetic thoracolumbar? So, more on thoracolumbar. So, tama naman. Pero aling region ng thoracolumbar? It's actually T10 to T12. So, tatandaan niyo yan. Pag sympathetic, thoracolumbar. And yung nagsasynapse siya with anong ganglion? Superior mesenteric. Small intestine, ito. Superior mesenteric, small intestines. Yan. So, yan. Tandaan nyo rin yan. Yung mga parts ng ganglion, baka itanaw. Tapos ito, pag sinabi mong sympathetic, short lang yung preganglionic, pero long yung postganglionic. Ayan. Yung mga ganitong questions, dapat ma-master niyo to. So, a 30-year-old man becomes ill after eating mushrooms. So, nasa ER na siya, treated for muscarinic poisoning. Which of the following signs consistent with muscarinic poisoning? So, muscarinic poisoning, sobrang taas ng parasympathetic activity mo. Yun lang, yung need nyong alamin. So, alin dito yung anong mag-result pag mataas yung parasympathetic activity? Mydriasis ba? Ano nga yung mydriasis? May D. So, D is dilation. So, pupillary dilation. Magdadilate ba yung pupils mo pag mataas yung parasympathetic? Hindi. Kasi pag parasympathetic, meiosis. How about bradycardia? Pag muscarinic poisoning, mataas yung parasympathetic mo. Bradycardia? Yes, pwede. Hypertension, parasympathetic? Hindi. Increased salivation, yes, parasympathetic. Pag mataas yung parasympathetic mo, yes, mataas yung salivation mo. So the answer is 2 and 4. 2 and 4. Mydriasis, pupillary dilation is sympathetic. Bradycardia, parasympathetic. Hypertension, more on sympathetic yan. Increased salivation, pwedeng both. Pero more on parasympathetic yung salivation. So the best answer is 2 and 4. So yun lang. Kailangan nilang alamin kung alin yung sympathetic effect or alin yung parasympathetic effect. Ito, which of the following is correctly paired? Your SA node, may nicotinic cholinergic receptors ba? Eh di ba sa heart, ano yung meron sa heart? Di ba yung meron sa heart is beta 1 tsaka muscarinic 2. So hindi. Autonomic ganglia, muscarinic cholinergic receptors, pwede. Pilomotor smooth muscles, beta 2 ba yung sa pilomotor? Radial muscle of the iris, alpha 1 adrenergic receptors, pwede. Yung best answer dito is letter D. Ay yung ano pa, sa autonomic ganglia. Hindi siya muscarinic, more on nicotinic 2. Pag sa skeletal muscle, nicotinic 1. Pag sa mga ganglia, yung meron sa kanila, nicotinic 2 receptors. Yung SA node, more on beta 1 or muscarinic 2. Pilomotor, more on alpha 1 yan. So tatandaan. Ito rin. Tandaan yung radial muscles ng iris. Alpha 1 yan. Alpha 1 receptors. So yun yung correctly paired. Which of the following statements about parasympathetic nervous system is correct? So the parasympathetic nerve activity causes contraction of the GI, smooth muscles, and relaxation of the GI sphincters. Parasympathetic activity. Yes, kasi di ba, more on sa GI yan. O contracting smooth muscles. And yes, opposite siya pag mga GI sphincters, relaxation yan. So pwede. Postganglionic parasympathetic nerves release ACH to activate your muscarinic receptors on sweat glands. Pag sweat glands ba, parasympathetic yun. Di ba? Isa sa exception ng sweat glands kasi more on sympathetic siya pero cholinergic. Sympathetic pero cholinergic yung sweat glands. So, hindi to. Parasympathetic nerve activity causes contraction of the radial muscles of the eye for near vision. Radial muscles, di ba sa radial muscles yung meron is alpha 1. So, hindi radial muscles yan. Parasympathetic nerve activity affects only smooth muscle and glands. Hindi, di ba? Hindi lang naman smooth muscles or glands, pwede rin yung cardiac mo. So, hindi. So, the answer here is letter A. Hindi siya radial na, hindi only, kasi pwede rin sa heart, di ba? M2 receptors. Sympathetic dapat to. Sympathetic sa sweat glands. Sympathetic cholinergic. Which of the following is correct about alpha 1 adrenergic receptors? So they are located mostly in the heart. Alpha 1, nasa heart ba? Napaulit-ulit tayo. Yung heart, only beta 1 or muscarinic 2 receptors. Yung alpha 1, more on blood vessels yun, di ba? Hindi. So their effects are mostly excitatory. So dapat alam mo ano yung mga secondary messengers ng mga alpha 1. Is it IP3? Is it cyclic AMP? Or inhibitory na cyclic AMP? So the answer here is letter B. So please remember this. No? Pag alpha 1, GQ protein yan. Pag GQ protein, yung G-coupled receptors mo, more on IP3 and diacylglycerol yan. Tataas yung calcium leading to smooth muscle contraction. Pag alpha 2, G inhibitory yan. Pag G inhibitory, dinidecrease yung cyclic AMP. Beta 1 to 3, lahat yan G stimulatory. So, sinistimulate na yung adenylyl cyclase, kaya mataas yung cyclic AMP. So, opposite ng GS tsaka GI. Yung GQ lang na iba kasi more IP3 siya. Kaya tandaan nyo, pag alpha 1, GQ protein yan. Pag GQ protein, more on IP3 and diacylglycerol, yung second messenger sila. So, yan yung correct. Tandaan nyo yan ha, pati yung sa muscarinic, alternating lang yan. No? Sa M1, M2, madali tandaan. GQ, GI, GQ, GI, GQ. Okay, next. So, which of the following responses is mediated by beta-2 adrenergic receptors? Oh, beta-2 naman. So, dapat alam mo ano yung nasaan ba yung mga beta-2 receptors? Vasodilation, bronchodilation, increased salivation. So, the answer here is A and B. So, yan ha. Tandaan niyo kung saan mo. Si beta-1, again, heart lang yan. Isa lang yung heart mo, kaya 1. Beta-2, dalawa yung lungs mo. So, 2. Pwede rin sa lungs. Yan o, airways. Pero pwede rin sa mga smooth muscles ng GIT, genitourinary tract, blood vessels. Yan, pwede rin sa blood vessels. So, pwedeng may vasodilation pag beta 2. Pag vasoconstriction, alpha 1. Beta 2, also sympathetic, vasodilation. Di ba walang role pag sa mga blood vessels, walang role yung parasympathetic. Parehas sympathetic pag sa blood vessels yung effect ng sympathetic. So, pwedeng vasodilation, beta 2, yan. Pwedeng bronchodilation, yes. Yan yung principle kung bakit tayo nagbibigay ng mga beta adrenergics or sa mga nahihirap huminga, may mga para magkaroon ng madilate natin yung airways leading to bronchodilation. Like your salbutamol, your SABA, short-acting beta agonist. Binibigay yan para may bronchodilation. Salivation, hindi. Walang salivation dyan sa beta 2. Mostly. So, which spinal cord level contains preganglionic parasympathetic neuron? So tandaan nyo lang, pag parasympathetic, anong division ba yan? Di ba sabi natin sa sympathetic, thoracolumbar. Pag parasympathetic, craniosacral. So anong level ng spinal cord? Yung may parasympathetic, thoracic, sacral, lumbar. Di ba parasympathetic, craniosacral. So S2 to S4. Parasympathetic, craniosacral. Sympathetic, thoracolumbar. T1 to L3. Ayan, cells of the adrenal medulla receive synaptic input from blank which releases blank. So adrenal medulla, tandaan nyo, iba yan medyo iba siya. Pag adrenal medulla, directly connected yan sa CNS. So more on preganglionic yan. Preganglionic. So hindi siya postganglionic. Hindi. So ito lang, A or B lang pag-isipan ng pag-adrenal. Is it preganglionic sympathetic or preganglionic parasympathetic? The answer is sympathetic. So tatandaan nyo, pag adrenal medulla, ito, pag di ba sa parasympathetic, long pre, short post. Yan. Parehas ACH yung i-release niya. Ano nga ulit sa mga ganglia? Ito yung ganglia mo. Ano nga ulit yung receptor sa ganglia? Nicotinic 2 receptors, di ba? So yan, ACH mag-bind sa nicotinic 2. So ma-stimulate yan, mag-release ACH sa target cell. Yun yung parasympathetic. Sympathetic, ayan. Your preganglionic is short lang. So mag-release ng ACH, mag-bind sa nicotinic 2 receptors, stimulate ito, mag-release naman ng norepinephrine kasi sympathetic na to. So usually lahat naman ACH ang ni-release except sa sympathetic postganglionic neuron. So pag adrenal medulla, ito, tingnan niyo ito. Yung solid red lines, itong mga red lines na yan, ayan, Yan yung preganglionic fibers. Itong mga ganyan, preganglionic fibers. Yung dashed blue lines, ito yung postganglionic, short lang. Nasa sympathetic tayo. So yan, tingnan nyo. Sa adrenal medulla, walang blue. Yung blue, di ba, is yung postganglionic fibers. So wala siyang postganglionic fibers. Diretso lang siya preganglionic hanggang medulla. And sympathetic siya. Sympathetic ah. Pero, di ba sabi natin sympathetic, norepinephrine nire-release? Eh hindi, kasi preganglionic pa lang to. Pag preganglionic, laging ACH. Ayan ah. Preganglionic, mag-release ACH, magbabind sa nicotinic 2. Dito naman sa parasympathetic, re-release din ng ACH. So, laging ACH yung nire-release ng preganglionic. So, tama to. Preganglionic, sympathetic, pero ACH. Kasi walang postganglionic. Pero pag postganglionic na sympathetic, yun ang norepinephrine or NE. So, tandaan yun ya. Direct sympathetic, tapos ACH yung adrenal medulla, tapos preganglionic. Walang postganglionic. Administration of an alpha-1 adrenergic blocker. Ayan. Iba-block naman natin yung alpha-1 receptors. Ano yung magiging effect pag blinak natin yung alpha-1? Heart rate? Alpha-1 being heart rate? Diba, again, sa heart is your beta-1 or your M2. So, walang effect yun sa heart. So, alin dito yung may pagblinak natin effect? Decrease sweating, increase intestinal motility, or failure of the pupils to dilate. Diba, nasabi natin kanina, yung radial muscles ng iris, alpha-1 receptors yung nandoon. Pag nag-bind, norepinephrine mag-bind sa alpha-1 will cause pupils to dilate. Pero blinak natin yung alpha-1. So, hindi makakadilate yung pupils. So, ito yung sagot. So, tandaan itong sympathetic and parasympathetic response sa pupils. Sympathetic may alpha-1 receptor. Pag nag-bind siya norepinephrine, it will cause mydriasis sa pupils to ha. Or pupillary dilation. Pag parasympathetic, M3 receptors yan, meiosis or pupillary constriction. So, hindi yung iba. So, pag blinak natin to, syempre, magkakaroon ka ng mydriasis? Hindi. So, failure of the pupils to dilate. Ito naman, parasympathetic dysfunction. So, wala kang parasympathetic effect. Dysfunctional kasi. Alin yung mag-i-increase dito sa choices na to? Alin yung mag-i-increase? Mag-i-increase ba yung heart rate? Pag wala kang parasympathetic? Pwede. Kasi mag-predominate yung sympathetic effects mo kasi wala kang parasympathetic eh. Intestinal motility. Wala kang parasympathetic. Hindi. Hindi mag-i-increase yung intestinal. Kasi yung tanong, which is will increase? Increase heart rate? Pwede kasi tataas yung sympathetic activity. Increase yung intestinal motility? Hindi. Increase yung bronchial diameter. Ayan, pwede. Kasi sympathetic, di ba? Beta 2 sa lungs. Beta 1 sa heart, isa lang yung heart mo. Beta 2, dalawa yung lungs. So, beta 2 is sa lungs. So, pag mataas yung, wala kang parasympathetic, mataas yung sympathetic mo, nag-predominate, pwedeng mag-increase yung bronchial diameter or bronchodilation. So, pwede itong dalawa. Salivation, hindi masyado kasi more on parasympathetic din. So, the answer here is letter A. 1 and 3. Wala kang parasympathetic, increase naman yung sympathetic mo. So, alin dito yung may increase sympathetic? Heart rate, pwede. Bronchodilation, pwede. Ito, hindi. How about ito? Administration of a drug that blocks the reuptake of norepinephrine by the prejunctional fiber will increase which of the following? Okay, so usually, di ba, para ma-stop yung activity ng norepinephrine, kailangan niya ng ma-reuptake pabalik sa presynaptic neuron. Pero pag mag-administer tayo ng drug na ibablock natin yung reuptake, tataas yung norepinephrine sa synaptic cleft. So, mas magbabind siya sa postsynaptic receptors. So, tataas yung sympathetic effects mo. So, alin dito yung mag-i-increase? So, ibablock natin reuptake, tataas yung norepinephrine, tataas yung sympathetic activity. Tataas ba yung intestinal motility pag mataas yung sympathetic? Hindi. Kasi di ba, parasympathetic yung rest and digest. Parasympathetic ang GIT. How about itong heart rate? Mataas yung sympathetic. tataas ba yung heart rate? Yes, pwede. Salivation, hindi rin. Kasi more on parasympathetic to. Pupillary size, sympathetic, di ba? Sabi natin, ay yung merong receptor sa iris, sa pupils, di ba? Alpha 1 receptors. So, pag mataas yung sympathetic mo, pwedeng mag-bind sa alpha 1 receptors yung norepinephrine, pwedeng mag-increase yung pupillary size and that is your mydriasis. So, ay mali ito. Dapat yung answer dito, mataas yung heart rate. Heart rate and pupillary size dapat. Kasi intestinal motility hindi yan tataas ha. So mali yung answer ko dapat. 2 and 4 yan. Tataas yung heart rate, tataas yung pupillary size mid-range. Kasi mataas yung sympathetic effects mo. Ito more on parasympathetic, more on parasympathetic. So a drug that potentiates the action of acetylcholinesterase. Ano pag ginagawa ng acetylcholinesterase? Dinedegrade yung ACH, your acetylcholine. So pag in-enhance mo, pag pinotentiate mo yung action ng acetylcholinesterase, edi masisirain yung mga ACH. So alin dito yung magiging effects daw? Ano ba ACH? More on parasympathetic. So meaning, wala kang ACH. Sinisira ng acetylcholinesterase yung ACH kasi na-potentiate mo. So, tachycardia ba? Constipation, bronchoconstriction, or vasoconstriction. So pag pinotentiate mo, decrease yung ACH mo. So decrease yung parasympathetic mo dito. Alin dito yung effects ng decreased parasympa? Tachycardia, hindi. Kasi decreased parasympa, ay tama, pwede ka tachycardia pala. Sorry. So decreased parasympa, so mataas yung sympathetic mo naman. So yes, tachycardia pwede. Constipation, mataas yung sympathetic mo kaya wala masyado GI motility kasi nga decrease yung parasympa. Pwede. Bronchoconstriction, mataas ngayon yung sympa mo. Hindi, dapat bronchodilation, di ba? Beta 2 yung sa airways. Vasoconstriction, hindi rin kasi mostly hindi. Yung best answer dito talaga, tachycardia constipation. Although mataas yung sympathetic activity mo, pwede mag-bind sa blood vessels, no? Pero more on ano siya, tachycardia constipation yung best answer. Okay, dito naman tayo sa cardiac physio and ECG. Okay, so ito yung need nyo tandaan. Kahit sa pagdating ng third year, ayan, medyo nalilito pa rin yung iba dito. Please memorize this by heart yung mga auscultatory locations ng mga heart sounds or yung valves. Ito yung nandito sa right. At, di ba yung S1? Ito muna pala. S1 is S1 heart sound is due to the closing of your AV valves. So ano ba yung AV valves mo? Ito yung mitral valve, tricuspid valve. So yan yung S1 pag nag-close sila. S2 is the closing of the semilunar valves which are pulmonary aortic valve. So tandaan niyo to. Dito sa right, second intercostal space, parasternal margin, dito yung aortic valve mo. Sa second intercostal space left, parasternal margin, dito naman yung pulmonary valve mo. Dito naman, tricuspid valve mo sa fifth intercostal space dapat to, left parasternal and yung mitral valve. And dito yung sa left mid-clavicular space. Tandaan nyo, APMT. So pag alam mo kung malalaman niyo usually kung ano yung problem sa mga murmur, kung ano yung mga abnormal. Kung alam mo yung location kasi pag sinabi sa case, may murmur ka na narinig sa right second intercostal space. So usually isipin mo, aortic problem ba yan? Aortic valving problem. Pag nasa left, second intercostal space, pwedeng pulmonic valve. Pag nasa left mid-clavicular line, pwedeng mitral valve. Or nasa left, fifth intercostal space, tricuspid valve. So, yung mga timing naman ng lesion. So, di ba meron tayong, dito tayo mag-focus sa mitral and aortic. may stenosis tayo, meaning ng stenosis, mitral stenosis, tumigas yung mitral valves. Ito yung example mo, ito yung typical, open. Tapos ito naman, nag-narrow, medyo tumigas. So, konti na lang yung dumadaan na blood. So, stenosis yan. So, yung timing ng murmur, tandaan nyo, ito yung mga timing. Diastole. Bakit diastole? Di ba pag diastole, ano ba yung diastole? Nag-relax yung heart, nag-fill yung ventricles ng blood. So, kung ganon, yung blood napupunta from the left atrium to the left ventricle. Yun yung diastole, nag-fill and narrowed. Konti lang yung pumapasok na blood, maliit lang yung arrow. So yung murmur, nangyayari sa diastole. Hindi sa systole. Pag systole, pag nag-contract na, ipupush yung blood papunta sa systemic circulation. Walang kinalaman yung sa systole yung mitral stenosis. Pero pag mitral incompetency or insufficiency, yung timing ng murmur niya, nasa systole. Meaning ng insufficiency or incompetent, hindi nagko-close ng maayos yung mitral valve mo. So during systole, pag nag-contract yung heart mo, babalik yung blood from the left ventricle to the left atrium. Kasi nga hindi nag-close ng maayos. Incompetent or insufficiency yung mitral valve mo, so bumabalik pag nag-contract yung heart. So, yung timing ng murmur na maririnig mo yun, pag mitral insufficiency, systole. Kasi pag nag-contract yung heart, bumabalik. Pag mitral stenosis, nag-fill yung ventricles, matigas, pumupunta yung blood from atrium to ventricles, doon mo maririnig during diastole yung murmur. Yan. Tapos pag aortic naman, so stenosis, tumigas yung aortic semilunar valves mo. Matigas. So, timing ng murmur, systole. Siyempre. Bakit systole? Pag nag-contract yung heart mo, dadaan siya siyempre dito. So, pag matigas yan, konti lang yung makakadaan na blood. So, mataas yung velocity. Maliit yung butas ng semilunar valve. So, nag-contract yung heart, pupush na yung blood, pero ang liit ng butas. So, konti lang yung lumalabas na blood. Mataas, pero mataas yung velocity, turbulent. So, yun. Dito yung timing ng murmur niya pag aortic stenosis. Pag aortic insufficiency naman or incompetent yung aortic semilunar valves mo, during diastole naman. Kasi pag na-push na yung blood, nandito na yung blood mo, di ba? Nasa aorta na. During diastole, mag-relax na. Pwedeng bumalik yung blood kasi hindi siya nagko-close ng maayos. Aortic insufficiency, hindi masyado nagko-close. So, pwedeng bumalik yung blood na nandito na, pwedeng bumalik dyan. So, yung timing ng murmur, diastole. So, yun yung importance ng timing ng mga murmur in comparison to your stenosis sa mitral or sa aortic. Same lang din yan sa pulmonic tsaka tricuspid. Next, pag-usapan naman natin yung automatic and non-automatic cells mo. Ano ba yung automatic cells? Di ba yun yung SA node tsaka AV node? Ito yung itsura ng action potential ng SA node mo at AV node. Slow yung depolarization, no? Tapos slow din yung repolarization. Pag non-automatic cells, tinutukoy dito yung atria and your ventricles. Non-automatic eh. Tapos tingnan nyo yung action potential niya. Diretso yung phase zero. Mabilis. Tapos ganyan. Sige, pag-usapan natin yung mga phases ng action potential dito. Pag automatic cells, again, SA node, AV node. Itong line na to, dito yung phase 4. Ito yung slow rise in membrane potential due to sodium leak channels. So, saan ba mataas yung sodium ulit? Extracellular. So, pumapasok yung sodium sa cell kasi may leak channels. Sa automatic cells to, kaya unique siya. Sodium yung pumapasok. Kaya, pumapasok yung sodium, ayan, tumataas ng konti hanggang sa ma-reach yung threshold. Ito yung threshold. Take note, negative 40 millivolts yung threshold ng automatic cells. Pag na-reach na yan, ayun na, depolarize na. Phase 0 na. Pero slow depolarization to. Di ba sa mga usual excitable cells natin, ano yung cause ng depolarization? Anong channel? That is your voltage-gated sodium channels. Pero dito iba. Dito sa automatic cells, yung cause ng depolarization is due to the long-lasting or the L-type calcium channels. So calcium influx, hindi sodium influx yung responsible sa depolarization ng automatic cells. Ayan, so calcium influx Kaya din slow siya. Wala siyang fast sodium channels. Mabagal to. Slow depolarization tapos slow repolarization. Then, again, repolarization is your phase 3. Nag-open lang yung voltage-gated potassium channels. So, potassium efflux. Tagal. Until ma-reach yung dito. Tapos may sodium leak channels ulit. Yun ulit yung phase 4. Yan. Yan yung sa automatic cells. Pero dito naman sa non-automatic cells is your cardiac muscles, your atria, your ventricles. May phase 1, phase 0 to 4 siya. Ito, RMP, phase 0, phase 1, phase 2, phase 3, phase 4. Parang dami nangyayari. So, phase 0. Ayan, may fast depolarization dito kasi tingnan mo, straight line. Ang bilis. So, dito naman, due to fast sodium channels. So, sa automatic cells lang talaga yung unique na yung phase 0 niya due to calcium, long-lasting or L-type calcium channels, yung depolarization. Pero dito, yung normal, voltage-gated sodium channels na fast. Fast, kaya yan. Mabilis yung depolarization. Pag na-reach na yung peak, yun na. Phase 1 mo is due to mag-open yung voltage-gated potassium channels leading to potassium efflux. Ayan, kaya buong nag-repolarize na. Pero, nag-open din dito. Usually, pag nag-depolarize, nag-open din yung calcium channel. So, during phase 2, ito na yung tinatawag na plateau. Yan, plateau. Yung net inflow, or yung pumapasok yung calcium. So, yung net influx ng calcium is balanced by the efflux of potassium. So, dito, di ba, bumabawas yung potassium, bumabawas yung potassium. Dito naman sa plateau, may pumapasok na calcium habang lumalabas pa rin yung potassium. So, balance yan, kaya plateau. Tapos eventually, dito sa phase 3, more potassium in efflux compared to the calcium influx. Mas maraming potassium na lumalabas kaysa sa calcium na pumapasok. So yan yan. And phase 4, ito na ulit yung resting membrane potential, your RMP. So yan yung sa the atria and ventricles mo. So itong cardiac cycle, ito important to. Sinummarize ko na ito. Sa 4 phases ng cardiac cycle mo, we have ventricular filling. So, siyempre, nag-fill yung ventricles mo ng blood. So, increase in volume. Pero little increase in pressure kasi may myocardial compliance tayo na tinatawag. Pag sinabing myocardial compliance, pag nag-increase yung volume, little increase lang yung pressure kasi compliant naman yung cardiac myocytes or ventricles natin. Isovolumic contraction. Itong phase naman ito, walang nangyayari. No change in volume. So, sarado dito yung mga valves. Yung AV valve na closed. Pero, increase in pressure kasi magsa-start na mag-contract yung ventricles mo. Isovolumic. Next is yung ejection phase. Di ba may rapid ejection tayo and reduced ejection. Pag sinabing rapid ejection, decrease in volume, yes. Pero increase in pressure pa rin. Kasi during this rapid ejection, nagko-contract pa rin yung heart mo. So, continue nagko-contract, kaya decrease in volume, pero patuloy nag-increase in pressure. Pero dito sa reduced ejection, yun, nagko-contract pa rin yung heart, babawasan yung volume sa ventricles, pero nagde-decrease na yung pressure. Kasi di ba important to? May tinatawag tayo dito protodiastole. Wherein, ito yung nagko-contract pa yung ventricles no, pero naghihina na. Hanggang sa mag-close yung semilunar valves. Ayan. Important yung protodiastole. Tapos, nextly, we have the isobolomic relaxation wherein no change in volume pero decrease na yung pressure. Tandaan niyo itong mga increased volume, increased pressure, tinatanong yan. Okay, ayan. Yung mga favorites ng mga graph sa cardio, PSHA. Wigner's diagram. So basically, itong Wigner's diagram na to, ito lang din yan. Itong AS, di ba? Atrial systole, isobolomic contraction, ejection, the rapid, the reduced ejection, isobolomic relaxation, and then you have the rapid inflow and diastasis. Take note din anong systole. Anong mga phases ng cardiac cycle under systole? It's starting from the isobolomic contraction hanggang sa ejection lang or the reduced ejection. Yan lang yung systole. Then everything else is diastole from the isobolomic relaxation hanggang sa atrial systole. Yan. So may iba't ibang lines tayo dito sa Wigner's diagram. Important na alam nyo rin to. Tapos alam nyo kung saan nag-open yung valve, saan nag-close yung valve. So, start tayo dito sa ventricular volume. Itong blue line na to. So, ito yung ventricular volume. So, basically, ito yung atrial systole. Ito naman yung isobolomic contraction. Ito yung ejection, isobolomic relaxation, rapid inflow, diastasis. So, same lang. So, tingnan niyo ito. Ventricular volume. So, tumaas yung volume ng ventricle dito sa atrial systole. Siyempre, nag-contract yung atrium mo para ma-eject yung blood from atrium to the ventricles. Kaya may ganyan, atrial systole. Kaya tumaas yung volume. Itong blue line, again, ventricular volume. Yung volume ng blood na nasa ventricle. So, siyempre, tumaas during atrial systole. Ito naman sa isobolomic contraction, walang, di ba nga sabi natin, no change in volume. So, dito sa ventricular volume, walang nag-change na volume dyan. Tapos sa rapid ejection, ayun. Decrease volume, increase in pressure. Ito, tingnan mo yung ventricular volume. Decrease sa ejection phase. Tapos dito ulit sa isobolomic relaxation, walang change. Ngayon sa rapid inflow, ito na. Nag-fill na ulit yung ventricles mo ng blood. Hanggang sa ganun. Next dito sa ventricular pressure. Ito. Di ba may tinatawag tayo dito sa ventricular pressure na A wave, your C wave, tsaka yung V wave. Ayan. Itong A wave na to, ito rin yan. Itong A wave, di ba nasa atrial systole? So bakit tumaas yung ventricular pressure sa A wave? So yan yung sa kapag nag-contract yung atria or atrium, tataas yung ventricular pressure kasi may dumagdag na blood. Yan yan. Tapos dito naman, nakikita mo itong point na to, dito nagka-close yung AV valve. Di ba? Pag nagka-close lang yung mga valves kapag pag nag-close lang yung valves, di ba? Kailangan mas mataas yung pressure sa ventricles compared to the atria. So ayan, tingnan mo. Itong broken lines, saan yung atrial pressure? So tingnan nyo dito, yung red line, yung ventricular pressure, mas mataas, sa point na to, mas tumaas na yung ventricular pressure compared to your atrial pressure. So because of that, magko-close na yung AV valve. So yan. And pag nag-close yung AV valve, anong heart sound nga ulit yun? Is it S1 or S2? It's S1. Okay, so ventricular pressure, di ba isobolomic contraction na tayo? O yung red line, tingnan niyo ulit, yung red line. Nagko-contract yung ventricles, pero walang change in volume, nagko-contract lang. Kaya ayan tumataas. Tapos hanggang sa ma-reach na ito. Itong broken lines naman dito, mga dashed line, ito yung aortic pressure mo. So at this point, mas mataas na around this area, mas mataas na yung ventricular pressure compared to the aortic valve. So kung mataas yung sa ventricular pressure compared to the aortic valve, mag-o-open na yan. So yan na, aortic valve opens at this point hanggang sa, ayan na, ejection phase na, mataas yung ventricular pressure, decreasing in volume. Pero dito, ayan, ayan di ba? Sabi natin sa reduced ejection, decreasing volume pero nag-decrease na rin yung pressure. Ito yun. Ventricular pressure, yung reduced ejection, decreased pressure na rin sa ventricles, pero nagde-decrease na rin yung nagde-decrease yung volume, pero nagde-decrease na rin yung pressure. Dahil yan sa protodiastole, medyo nag-weaken na yung ventricular contractions mo dito sa part na to. Hanggang sa saan ba nagko-close yung aortic valve? Ayan na. Mas pag mataas na yung aortic pressure compared sa ventricular pressure, magka-close na dyan yung aortic valve. Hanggang sa bumalik na ganyan. Again, yung mga A-wave, C-wave, B-wave ng atrial pressure, tandaan nyo yan. Yung A-wave dahil sa atrial systole, yung C-wave dahil yan sa pag nag-contract na yung ventricles, nagbabulge yung mga AV valves pabalik sa atria. Yan yan, yung slight na bump na ganyan. Tapos ito, nagsa-start na yung atrial filling dyan. Okay, so tandaan nyo yan, yung mga phases. Pati kung aling part lang yung systole, pati yung diastole. Tapos ito, tinatanong din to anong part ng ECG, yung mga ibang phases. Mamaya, sagutin natin sa questions. Okay, so next we have the volume pressure ejection loop. Ayan, natatandaan niyo pa ba to? Isa din to sa mga favorite na graphs, di ba? So, alam niyo na yung mga phases. So basically, from here, from point A to point B, this is your period of feeling. Tapos yung point B na to, ito yung end diastolic volume mo. Take note, ito yung volume. So, 1/3 around here, mga 120 ml yung volume na nasa end diastolic. Tapos ito yung phase 2. Phase 2, which is yung isobolomic contraction. Pressure lang yung tumataas, walang change sa volume dito sa baba. Kaya, pressure lang yung tumataas. Yung pressure itong y-axis, volume itong x-axis. So, pressure lang yung tumataas. Hanggang sa mas mataas na yung pressure sa ventricles compared to the aortic pressure, mag-o-open na yung AV valve at this point C. Tapos dito, period of ejection na. Pero dito sa isang graph, may C1. Itong point C to C1, that's your rapid ejection. Mataas yung pressure, pero nagdi-decrease yung volume from here to here. No? Nag-decrease yung volume, pero mataas pa rin yung pressure. That's your rapid ejection. From point C1 to point D, ito na yung reduced ejection. Nagdi-decrease na yung pressure ng ventricles, nagdi-decrease pa rin yung volume. So itong ejection phase, yan rin yung itong E corresponds to your stroke volume. Yan yung nabawas kasi di ba ito yung end diastolic volume, tapos naging ito na lang, end systolic volume. Pag sinabi mong end diastolic volume, yan yung volume ng blood na nasa ventricles mo after diastole. So nandito yan sa point B. Tapos point E naman, nandito yung end systolic volume or ESV. Ito yung ESV, yung volume ng blood na nasa ventricles after systole. So usually around 50 ml, may natira pang blood. So yung point F na yan, itong line F na yan, that's your ESV, end systolic volume. Your E is your stroke volume. Kung ilan yung nabawas na blood from EDV, tapos hanggang sa ESV. Okay, basically yan, isobolomic relaxation din to. Walang no volume change. Basta pag may mga isovolumetric or isobolomic, no change in volume, pero may change in pressure. Pag relaxation, siyempre decrease in pressure. Pag contraction, siyempre increase in pressure. So ito mga formulas and normal values, tandaan nyo rin to. So very important. Di ba yung cardiac output mo, yung formula na is stroke volume times heart rate. Pero pag blood pressure, it's cardiac output times total peripheral resistance or yung afterload mo, yung pressure mo sa systemic circulation, total peripheral resistance. Stroke volume is your EDV minus your ESV, di ba? EDV minus ESV. So mamaya, yung pinapa-compute rin, di ba, sa mga graphs. So anong formula ng stroke volume? EDV minus ESV. So EDV, itong 150 minus ESV, 150. So ilan yung stroke volume dito sa example na to? It's from 150 minus 50. Ayan, 100. Yan yung stroke volume. Itong ejection fraction din, tandaan yung formulas. Stroke volume over the end diastolic volume times 100. And yung normal value is cardiac output about 5 to 6 liters per minute. Stroke volume, usually 70 ml average. End diastolic, 110 to 130. Pero ESB 45 to 50 usually. Pinapasolve yan sa mga graph minsan. Sige, let's start answering questions naman. So which phase of ventricular muscle action potential is most dependent on increased calcium influx? Ayan. Ventricular muscle action potential, so that's your fast-paced action potential. Saan siya? Anong phase yung may increased calcium influx? So fast action potential, ha? Ayan, okay, mali to. Automatic cells, yung slow response. Yan yung SA node, AV node, mabagal. Pag non-automatic cells, your atria, ventricles, yun yung fast response. So phase 2, kasi di ba nandito yung plateau. Calcium influx, tapos potassium efflux, balance yan, kaya plateau. So most dependent sa phase 2 yan. Kasi yung tinatanong ventricular muscle, so dito tayo. Hindi ito. So in a resting adult, the typical ventricular ejection fraction has what value? O, di ba? Na-mention natin yung normal values ng ejection fraction then, which is about 65 to 75%. Kung may papasolve sa inyo, just about ejection fraction, just remember this formula. Stroke volume over EDV times 100. Pero it usually ranges ng 65 to 75. Pag nag-lower na dyan, mababa na yung contractile function ng heart, bumababa. Delikado na yan. So in a cardiac cycle, when does the first heart sound occur? Madali na to. Di ba? First heart sound, S1, is due to the closing of your AV valves, your mitral valve or tricuspid valve. So saan siya nag-occur? End of diastasis? Hindi pa. End of atrial systole, beginning of rapid ejection, or beginning of ventricular filling. So dapat, again, alam niyo yung graph. Ito, first heart sound, di ba? Ito, AV valve closes. Ito yung S1 mo. So saan siya nag-occur first, no? Ito yung atrial systole, di ba? Itong portion, itong phase. So atrial systole, ayan, kasi tumaas na yung ventricular portion, ventricular pressure mo, magka-close na yan. At the end of atrial systole, kasi ito yung atrial systole. Itong atrial systole end. Diyan na close yung AV valves, and that is your first heart sound or your S1. So which event is associated with second heart sound naman? Second heart sound, S2. Di ba? Yan yung closing. Closing lagi hindi opening. Closing of your semilunar valves. So, closing of the aortic valve. Pwede. Opening of the mitral valve ay hindi. Rushing of blood to the ventricle ay hindi. Kasi yung sound lang is due to the closing of the heart valve. So, the answer is easy na yan. Closing of the aortic valve. Ito. Which phase of the cardiac cycle follows immediately after the beginning of QRS wave? Paano mo malalaman to? Paano masasagutin to? Which phase of cardiac cycle, yung beginning ng QRS? Ayan, kinakorrelate yung ECG. So, aling phase dito? So, kailangan nyo dito ng ito ulit. Ang tanong, follows immediately after the beginning of QRS wave. Tingnan yung ECG na to, yung electrocardiogram. Ito yung P wave, ito yung Q, ito yung R wave, yung S wave. And this is your T wave. So, after daw ng beginning ng QRS wave, saan ba nagsimula yung QRS wave? Ito yung QRS. So, nagsimula siya dito, atrial systole phase. So, anong cycle daw yung after ng nagsimula yung QRS? Dito nag-start yung QRS. After nyan is isobolumic contraction. Itong phase, isobolumic contraction. So, that's why ito yung sagot. So, wag malito after the beginning. So, ang tinatanong, beginning ng QRS. So, ito yon dito sa atrial systole. After ng atrial systole, isobolumic contraction. Kaya, yan yung sagot. How about this? Which of the following factors will increase the end diastolic volume? EDV. So, increase in heart rate. Tataas ba yung EDV mo dyan? Decrease in myocardial compliance, increase in venous return, more negative intrathoracic pressure. So the answer here is 3 and 4. Kasi of course, pag sinabi mo venous return, yung blood bumabalik sa right atrium mo. So pag bumalik yung right atrium, edi mas maraming blood yung mapupunta ulit sa ventricles. So increase in venous return, tama. Ito rin, more negative intrathoracic pressure. Pag mas negative, mas tataas din yung venous return. So tandaan niyo, the more negative yung intrathoracic pressure, mas tataas yung venous return. So in turn, ayan, these two factors will increase the ADV. Hindi heart rate, decrease yan. Dapat increase in myocardial compliance to. Okay, which of the following cause and effect is incorrect? So cause ito, then ito yung effect. So pag ba may increase in afterload, there's decrease in end systolic volume. Ano ba yung ESV? Ito yung volume ng blood na natira sa ventricles after systole. So increase in afterload. So mahihirapan mag-pump yung heart mo kasi ang taas ng afterload or total peripheral resistance. Magdi-decrease ba yung ESB? Hindi. Dapat mag-i-increase yung ESB. Kasi pag hindi mo, mahihirapan yung heart mo i-pump yung blood from ventricles to the systemic circulation or to the aorta. Kasi mataas yung afterload. So dapat tataas yung ESB kasi mas nagsistay. Konti lang yung napapump na heart. Dapat increase yung ESB. Increase in EDB, increase in stroke volume. Yes. Di ba may tinatawag tayo yung Frank-Starling mechanism or law? Basically, sinasabi lang nun, pag na-stretch yung ventricles mo, the more na na-stretch yung ventricles mo sa heart or myocardium, the greater the contraction ng heart mo. Yun yung Frank-Starling law. So, if you have increase in EDV, meaning mas marami yung volume of blood, mas stretch yung ventricles mo. So, because of the Frank-Starling mechanism, magi-increase din yung stroke volume. So, tama yan. Increase in myocardial contractility will lead to decrease in ESB. Yan yung tama. Pag mas mataas yung contraction ng heart mo, mas maraming mapapump na blood ng ventricles to the systemic circulation. So, konti na lang yung matitira. Decreasing ESB or the blood na natira after systole or contraction of the heart. So, ito dapat yung tama. Pag increase after load, increase yung ESB. Mas matitira yung blood sa ventricles. Increase in heart rate, increase in end diastolic volume. Yes, kasi pag in-increase mo yung heart rate, mas mai-stay yung blood, hindi masyado mapapump. Kasi, pag in-increase mo yung heart rate, madi-decrease yung diastolic period mo, no? So, pag na-decrease yung diastolic period mo, konti lang yung ventricular filling, pero eventually, cause ng increase in EDV. So, increase in afterload, yan yung mali dito. Next, sympathetic stimulation of the heart has the following effects, except sympathetic sa heart, except facilitates myocardial relaxation. Yung sympathetic, yes, may myocardial relaxation tayo dito. Tinatawag pa nga natin itong lusitropic effect. Tandaan nyo yun na. Sympathetic, may lusitropic effect din yun. Siyempre, sympathetic. Mag-i-increase yung excitability ng SA node, kaya mag-i-increase yung heart rate. Yes, correct din to. Napoprolong yung AV conduction time? Hindi. Kasi pag nag-prolong, ano yan, mas tatagal yung conduction from the atria to ventricles. Pag sympathetic, tinataas natin yung SA node, di ba? So, dapat shortens. So, malito. Ting except. Increases myocardial contractility. Yes, sympathetic. Beta 1. May increase yung heart rate or chronotropy. And sympathetic, beta 1, increases contractility or your inotropy. So, ito yung mali. Lusitropic effect part, din yan ng sympathetic stimulation. Ito, what is the membrane potential or the threshold level at which the SA node discharges? SA node. So, nasa graph yan kanina. Negative 40, 50, 60, or 90. Siyempre, negative 40. Ito yan. Ito yung threshold potential sa automatic cells or SA node. Negative 40 millivolts. Tandaan. The work performed by the left ventricle is substantially greater than that performed by the right ventricle because in the left ventricle, ayan, the wall is thicker. Bakit greater yung work na performed by left ventricle? Wall is thicker, contraction is slower, preload is greater, afterload is greater. Siyempre, yung nasa left, di ba, mas mataas yung afterload compared sa right ventricle or going to the pulmonic circulation. Mas mataas yung afterload sa left ventricle kasi pag ganon, kailangan mas mag-work harder yung left ventricle mo para excrete or ma-pump yung blood to the systemic circulation. Yan din yung principle na bakit nagkakaroon ng sa pathologies natin, di ba? Pag may increased workload yung left ventricle mo due to increased afterload or total peripheral resistance nagkakaroon ng pathologic changes kung hindi na correct, leading to left ventricular hypertrophy. Lumalaki yung muscles sa left ventricle para mas mataas yung lumakas yung contractions para ma-deliver yung blood to the systemic circulation to counter yung afterload. Yung next, 65-year-old man is referred to a cardiologist for evaluation, physical exam reviews. Ayan. Diba? Minention ko yung mga about sa mga murmur this time. Diastolic murmur prominent over the right sternal border. Ayan. Anong valve yung nasa right sternal border? Right. So, di ba that's your aortic valve. So, yun. Ayun. Ano dito yung aortic valve? O, ito na. Tapos, para sure tayo, regurgitation dito. Diastolic murmur. Right sternal border. So, alam natin that's aortic valve yun. Kasi yun lang naman yung nasa right. Tapos, diastolic yung timing ng murmur. Di ba pag aortic regurgitation, or aortic insufficiency or incompetent yung aortic valve mo, sa anong timing ng murmur? Ayan. Aortic regurgitation. Aortic incompetency or insufficiency or regurgitation, the timing is diastole. Kaya naririnig mo diastolic murmur. Tapos yung location, right sternal border, ano? Ito ulit to, right sternal, that's your aortic. Pero yung timing ng murmur, diastole, so it is aortic regurgitation. So, sa location pa lang, maka-cross out mo na agad yung ibang choices. Kung alam mo yung location ng auscultatory heart sound, ay ng valves. Tapos yung timing ng murmur. Kasi di ba pag incompetent, na-deliver na ng left ventricle yung blood to the aorta, pero during diastole, yung blood na nasa aorta, babalik sa left ventricle. Kasi incompetent ngayon, hindi masyadong, hindi maganda yung closing ng aortic semilunar valves. Kaya bumabalik from the aorta to the left ventricle. The aorta to the left ventricle, bumabalik. So, diastole yun. During diastole, incompetent yung aortic valve mo. A decrease in ventricular volume with an increase in ventricular pressure, ayan. Of course, at what pace? So, tingnan. Decrease na yung ventricular volume. Nagdi-decrease yung volume. So, possibly, ano na yan, ejection phase. Nagdi-decrease yung volume, ina-eject na yung blood. Pero may increase pa rin ng ventricular pressure. So, the answer is rapid ejection. Diba? Decrease in volume, increase in pressure. Nagko-contract pa dito yung heart. Nagko-contract, ayan, increase volume, pero nagko-contract yung heart, kaya yung ventricles, kaya may increase pa rin yung pressure, pero sa reduced ejection, nagko-contract pa rin yung heart, kaya nadi-decrease yung volume, pero decrease na yung pressure kasi, again, tandaan, may protodiastole tayo wherein this is the phase where the ventricular contraction, nagko-contract pa, pero humihina na, nag-weakens na until the closing of your semilunar valves. So, yan ang tandaan yung mga changes na yan for each phases ng cardiac cycle. Okay, how about sa discussion? Aortic pressure is higher than ventricular pressure except during aortic pressure. Mas mataas na sa ventricular pressure. Actually, ganun naman talaga, di ba? Except na lang kung yung ventricular pressure mas mataas sa aortic. So, saan yun nangyayari? Ventricular filling, hindi. Hindi. Rapid ejection, yes. Kasi di ba ito yun. Aortic pressure, ito yung aortic pressure mo ulit. Ito yung mga broken dashed lines mo. Ito na yung ventricular pressure mo, ito namang red line. Itong red line, ha. So, ditong point na to, rapid ejection, tandaan. Divided pa to into two, di ba? Ito yung rapid ejection, ito yung reduced ejection. So, tingnan nyo sa rapid ejection, mas mataas yung ventricular pressure compared sa yung broken dash line na yan, which is your aortic pressure. So, ditong phase na to, rapid ejection yan. Diyan siya mataas. Which is true regarding ECG in relation to the cardiac action potential. End of year interval is the beginning of phase 0. Ayan, so dito naman, kailangan mo alam yung paano i-correlate yung cardiac action potential sa ECG. So, eto yan. So, tingnan nyo. Ito yung ECG, P-wave, QRS, T-wave. Tapos ito naman yung ayan, ventricular, non-automatic action potential. So, tingnan. End of PR interval is the beginning of phase 0. End of PR interval, ito yung PR, so ito yung PR interval. So, itong line na to, PR interval, beginning of the phase 0. Yes, ito yung phase 0, di ba? Ayan, phase 0. Because of the fast sodium influx. So, yan, kaya yun yung sagot. P-wave corresponds to phase 1. Ito yung P-wave mo. Pero andito yung phase 1. So, hindi. Nasa QRS yung phase 1. Sa QRS yung ka-alive. Yung P-wave, hindi. So, mali yan. QRS duration is equal to phase 3. Ito yung QRS. Ito yung phase 3. So, hindi siya align. Yung QRS more on sa phase 1. Kaya mali. Mali din to. So, tandaan niyo yan. Ito yung action potential correlating to your ECG. ST segment occurs during phase 2. ST segment, ito yung ST segment. Pag sinabi mong interval, yung buo. Pag segment, yung segment lang. So, ito yung S, ito yung T, ST segment. So, ST segment occurs during phase 2. Pwede rin actually pala. Align din siya. So, actually possible din. Which is not true regarding QT interval. QT interval. Balikan natin. QT interval. Ito yung atrial contraction mo and atrial depolarization, yung P-wave. Yung QRS mo reflects your ventricular depolarization. Your T-wave corresponds to your ventricular repolarization. So when you say QT interval, itong buo na to, it emphasizes on your the action potential of your ventricle. So not true regarding QT interval. The period from ventricular isovolumic contraction to isovolumic relaxation, proportional ba to heart rate, T-wave to the end of T-wave, or time taken for ventricular depolarization and repolarization. So the answer here is QT interval. Ito yung mali. So period from ventricular isovolumic contraction to isovolumic, yes. Align din yon. Ito hindi. Yung QT interval, hindi siya directly proportional to heart rate. So ito yung normal QT interval. Pag nag-prolong yung QT interval, meaning mas bumabagal. So ano yan? Pag decrease yung heart rate, prolong yung QT interval. So hindi siya directly proportional but rather inversely proportional. Yan yung not true. And yes, the time from the start of Q wave to the end of T wave. Yan yung QT. Ito yung Q wave, nandito na part, hanggang sa T wave. Time taken for ventricular. Yes, di ba sabi ko, yung QT, itong QRS, ventricular depolarization. Yung T wave, ventricular repolarization. So, together, that's your ventricular depolarization and repolarization. So, correct yan. So, again, inversely proportional dapat yung QT interval. Complete atrial and bundle branch dissociation. Dissociated na. So, hindi nakaka-transmit yung signals from the atria to the bundle branch papuntang ventricles. So, alin yun dito? Complete bundle branch block? Hindi. Third degree AV block? Pwede pa. So, the answer is third degree AV block. So, tandaan yung mga different types ng AV block. Usually, tinatanong din yan. No? So, we have this first degree AV block. Yung nangyayari lang dito, nag-prolong yung AV segment. Dito naman sa second degree, nag-prolong na. Ito progressive. Dito, from here, ito medyo nagpro-prolong, hanggang sa mag-prolong, hanggang sa nawala na yung QRS. That's your Mobitz type 1. Second degree AV type 1 or Mobitz type 1. Progressive yan Ito prolonged lang yung yung AV. Tapos dito naman, yung Mobitz type 2 yan. Tingnan nyo, consistent siya. Parang normal naman. Tapos bigla na lang nagkaroon ng drop beat. Yun yung pinagkaiba niya sa Mobitz type 1. Pag sinabi mong second degree AV block, progressive, tumatagal yung PR interval pala, PR interval. Dito naman, normal, normal, tapos bigla na lang drop beat. Walang QRS, oh. Di ba? QRS, wala. Drop beat yung tawag dyan. So normal, tapos biglang drop beat. Second degree AV block yun. Or Mobitz type 2. Pag type 1, nag-progressive hanggang sa mawala, drop beat. Pag third degree AV block, ayun na, wala na. Complete heart block na to. Ano na lang, excessive P-wave na lang, wala nang QRS. Medyo delikado na yan. So yung complete dissociation for the atria, third degree AV block dito, kasi wala na talaga. Hindi, ayun no? Yung P-wave na lang natira. Wala nang QRS, hindi na na-reach sa ventricles yung signals. So dissociated na yung atria sa bundle branch. 82-year-old female came in due to syncope and persistent dizziness. So ECG was done and you heard the medical resident state that the patient has type 2 second degree AV block. Pag sinabing type 1 again na AV block, progressive. Pag type 2, normal, normal, normal. Tapos biglang nag-drop beat. Ayan. So which of the following best describes such an ECG finding? The P wave is persistently more than 0.2 seconds. Progressively prolong yung PR interval, di ba? Type 1 to, yung progressive na nagpo-prolong. At drop beat is seen after every 3 normal complexes. Yan. Again, tandaan niyo itong image. Yung second degree type AV block na type 1, progressive, nagpo-prolong yung PR interval, tapos biglang naging drop beat. Wala nang QRS. Dito naman, normal, 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 tapos biglang nag-drop beat. Second degree AV. Drop beat seen every after 3 normal complexes. Which of the following electrolytes will most likely affect the duration of QT interval? Ayan. So, dapat alam niyo ulit yung QT interval sa action potentials. Ayan. Affect the duration of QT interval. Yung QT interval mo ito. Diba? QT interval. So, align siya sa about phase 2 ng cardiac action potential. So, the following electrolyte, yung most likely na ma-affect during the QT interval is calcium kasi ditong phase na to na phase 2, yung influx ng calcium. So kung may problem dyan, affected to. Okay, next, dito naman tayo sa vascular physiology. So, may picture pero kaya na natin without answering. So, almost 8,000 feet above sea level. So, the common symptom felt by tourists is tachycardia. So, dito na tayo sa vascular. No? So, regulatory mechanisms naman, anong mag-i-explain tachycardia? So, yung clue mo dito, 8,000 feet above sea level. So, mataas yung altitude. So, the answer here is your chemoreceptor, hindi nakita. Your chemoreceptor reflex. Basically, ito yung sa mga high altitudes. So, pag high altitudes, medyo bumababa yung oxygen mo dito. Pag mababa ang oxygen mo, active yung reflex. Masa-sense yan oxygen ng chemoreceptors mo na mababa yung oxygen. Ayan, masistimulate yung activation ng sympathetic nerves mo leading to tachycardia. Reflex yan. Chemoreceptor. Pinagkaiba niya sa baroreceptor, more on blood pressure to. Ito kasi, nasa high altitude mababa yung oxygen, chemoreceptor yung oxygen, chemical. Baroreceptor, more on pressure, blood pressure yun. So, what regulatory mechanism is depicted in the picture? So, yung picture, pinapakita lang ng tourniquet and blood drawing. So, pag mga tourniquet or blood drawing, ang nangyayari dyan is reactive hyperemia. Ito yan. Yung reactive hyperemia, basically, ito yung pag blinak mo yung blood vessel. Inocclude mo yung blood flow. So, tissues blocked, then unblocked. Like applying BP cuff or you're applying tourniquet, the blood flow through the tissues is increased to several times the normal. The increase in flow will continue for as long as the tissue has been blocked. Yan. So, basta kung sa mga vessel occluding, reactive hyperemia yun. nagkakaroon ng vasodilation sa affected na occluded ng blood vessel hanggang sa pag ni-release mo na, mataas yung blood flow doon hanggang sa mag-normalize. So, increase in flow will continue for as long as the tissue has been blocked. Ang compared niyan, yung reactive hyperemia sa mga occluding vessels, pag active hyperemia, dahil yun sa active metabolizing tissues mo. So, kung actively metabolizing yung tissues mo, edi may mga metabolites ka. Ayan, yung mga metabolites na yun yung magkakos ng blood vessel vasodilation. So dahil to sa metabolites, ito dahil sa occlusion ng blood vessel, yung reactive. Yun yung pinagkaiba ng active sa reactive hyperemia. Because of the air conditioning system's poor, a professor drank 7 glasses of water while delivering an online lecture. So, at the middle of the lecture, she excused herself to urinate. So, anong regulatory mechanism to? Ito na yung clue mo. Uminom siya ng 7 glasses of water. So, ang daming water niyan. So, pag uminom ka ng water, mapupunta yun sa blood volume mo, tataas yung blood volume. So, temporary increasing your blood pressure, temporary lang Pero, may regulatory mechanism naman tayo which is your renal fluid shift. Kasi pag mataas yung blood volume mo, di ba? Pag mataas yung blood volume kasi inom ka ng inom ng tubig, tataas yung venous return. Pag tumaas yung venous return, mas tataas yung volume na nasa ventricles, increasing your EDV. And as stated as the Frank-Starling law mechanism, as na-stretch yung ventricles, tataas na ngayon yung contraction, hence increasing stroke volume. Pag na-increase yung stroke volume, increase cardiac output. Pag nagtumaas ito, increase BP. Pero, hindi naman temporary increase in BP lang kasi yung blood volume mo mataas. So, yung more blood will go to the afferent arteriole of your kidneys. So, kakaroon ng increased glomerular filtration. Mas mafi-filter yung blood volume kasi mataas yung blood volume. So, ngayon, matataas yung tubular fluid and mas tataas yung urine output mo. So, basically, renal fluid shift, iihi mo lang yung excess na water na nainom para ma-normalize yung blood pressure mo. Yan yung renal fluid shift. Hindi itong iba. Hindi RAAS, hindi vasodilator, autoregulation. Ito, a premature neonate stayed in incubator with 100% oxygen for 1 month. So at 1 year of age, retrolental fibroplasia or the blindness due to vessel overgrowth was evident. So anong regulatory mechanism yung nangyayari dito? So, include dito yung incubator ng 100% oxygen. Ito yung tinatawag natin na change in tissue vascularity if hindi niyo maalala. Basta ito yung, di ba, kapag premature yung neonate, premature din yung lungs. Kaya usually, di ba, nagbibigay tayo ng mga steroids like your betamethasone, dexamethasone to accelerate yung lung maturity ng premature neonate. Pero pag premature neonate, pwede mo rin siya ilagay sa incubator na may mataas na oxygen levels para ma-support yung lungs. Pero, yung high levels na oxygen sa incubator, ma-affect niya yung eyes. So, this stops the blood vessels sa retina from growing. So, nawawala yung blood vessels sa eyes kasi dahil sa mataas na oxygen. Yan yung change in tissue vascularity. So, pag nilabas mo agad yung neonate ng biglaan, from the incubator, may expose agad siya from high levels ng oxygen to low levels sa environment. So yung mangyayari, nawala na yung oxygen, so kakaroon ng explosive growth of blood vessels sa retina. Yun. Dahil dyan, makakover yung blood vessels sa retina, covering the entire portion of the eyes, and that could lead to blindness. And tinatawag natin yung retinopathy of prematurity. So yan yung dito, change in tissue vascularity. Ayan. When the RAAS is stimulated, everything will increase except, alam niyo pa yung RAAS, your renin-angiotensin-aldosterone system. Pag na-stimulate mo yan, ano yung mag-i-increase? Venous compliance, increase ba? Total peripheral resistance, yes. Kasi di ba, RAAS stimulates arteriolar vasoconstriction, yes. O pag nag-vasoconstrict yung vessel, tataas yung total peripheral resistance, tataas yung blood pressure. Remember the formula. Blood pressure is cardiac output times total peripheral resistance. Tumaas ito, tataas yung blood pressure. Venous return, tataas din? Yes, kasi Magva-vasoconstrict nga. So, yung mga blood sa veins pwedeng bumalik sa right atrium. Except this. Hindi ito mag-i-increase pag na-stimulate yung RAAS. Pag sinabi mong venous compliance, pag increased, yung blood magpupul sa veins. Nasa veins lang sila. Hindi babalik sa right atrium. Konti lang yung babalik. So, mag-decrease yung venous return. Pero yung venous compliance na decrease, pag decrease yung venous compliance, hindi ma-hold sa veins. So, mababalik sa right atrium kasi magko-constrict yung vein. Kasi, kaya di ba yung tawag sa veins na capacitance, vessels? Ayun, kasi hino-hold nila yung blood. So, dapat decrease to pag na-activate yung RAAS. Hindi, pag na-activate yung RAAS, hindi naman magva-vasodilate yung veins mo eh. So, which is a correct statement about microcirculation? The hydrostatic pressure is high at the venular end. O, di ba na-mention din natin sa blood pressure kanina about sa Starling's forces. Di ba sa arteriolar end, yung more on filtration, doon yung mataas yung hydrostatic pressure. Sa venular end, yun yung more on reabsorption. So, dapat, hydrostatic pressure is high at the arteriolar end. Malito. 1/10 of the filtration at the arteriolar end does not go back to the veins. So, pwede. The sympathetic nervous system causes capillary constriction. Tama ba? Sympathetic, yes. Alpha 1, di ba? Sympathetic. Alpha 1. Masistimulate alpha 1, magkakaroon ng vasoconstriction. Pero, anong nagpamali dito? Capillary constriction. Nagko-constrict ba yung capillaries? Hindi. Arteriolars yung nagko-constrict. Kaya malito, hindi capillary. Speed of blood is fastest in this area. Ay, hindi. Kasi di ba sa microcirculation or your capillaries, dapat mabagal yung blood, mabagal yung velocity. Ay, hindi na naman makita. So, yung figure. So, dapat mabagal yung blood mo. Ay, yung velocity ng blood doon. Kasi, di ba, sa capillaries nag-exchange ah, yung mga oxygen, yung carbon dioxide. So, dapat mabagal, hindi mabilis. So, dapat slow. I think correct. In old age, the following increases except old age. Tataas yung blood pressure, pwede. Pulse pressure, pwede. Vascular resistance, pwede. Arterial compliance, tataas ba yun as you age? Hindi na. Kasi as you age, nagdi-decrease na yung arterial elasticity mo. So, leading to decrease in arterial compliance. Mas nagiging rigid na yung blood vessels mo. Kaya tumataas yung blood pressure. So, yun, madali na yan. So, which circulation is in series? Mesenteric, renal, coronary, or cerebral? So, pag sinabi mong series, ito yan. Yung flow ng vessels, dire-diretso. In series siya. Example sa renal, di ba? From afferent arteriole, the glomerulus, to the efferent arteriole, and then to the tubules. Capillary tubules or even vasa recta. So series yon, sunod-sunod. From afferent to the glomerular to the efferent, tapos sa ibang capillaries. Dito sa iba, pag parallel kasi itong iba, meaning yung blood flow, multiple, madaming, hindi lang isa, hindi lang straight, madaming dinadaanan niya sa mesenteric, coronary, cerebral. Except, ayan, parallel arrangement except in portal circulation in the blood and even in the kidneys. Yun yung parallel. Maraming blood vessels, so hindi siya sunod-sunod unlike sa renal mo. Sa renal, or even sa portal circulation, di ba? From the splanchnic circulation to the portal vein to the liver and mag-exit sa hepatic vein. So sunod-sunod, in order. Yun yung series. In order siya. Ito, hindi siya in order. Madaming blood vessels siya, basically. So a 55-year-old male had a severe myocardial infarction 1 year ago. Is now suffering from hypotension, pulmonary edema, massive ascites. So alin dito yung increase? Cardiac output ba increased? Hypotensive na nga, oh. Di ba? Mababa na yung blood pressure, so hindi. Tapos tingnan mo, may pulmonary edema, massive ascites. So, suggestive na to ng congestive heart failure. Pulmonary blood pressure, increased ba? Pwede. Kasi di ba may pulmonary edema. Especially na sinususpect natin na ano to, congestive heart failure. So kung may problem sa left ventricle or left-sided heart failure, nagkakaroon ng congestion. Hindi na napapump yung blood from ventricles to the systemic, so mag-accumulate sa ventricles, pabalik sa left atrium, pabalik sa pulmonary veins to the pulmonary circulation. So magiging congested yung blood vessels mo sa pulmonary circulation. So pwedeng tumaas yung pulmonary blood pressure mo. Venous return, hindi rin. May filtration, hindi rin. Kasi mababa na nga yung hypotensive ka na nga. Konti lang mapupunta sa afferent arterial mo sa kidneys. So, pulmonary blood pressure. Normal maternal adaptation during pregnancy includes increased blood volume and decreased total peripheral resistance. So, what is the expected blood pressure during pregnancy? Ayan, nandito na actually yung clue. Pag pregnancy, di ba? Yung normal response is tumataas yung blood volume. Pero, may decrease din yung total peripheral resistance, di ba? Yung progesterone, for quiescence, dapat relax yung mga smooth muscles. So, that's why nagkakaroon ng decreased total peripheral resistance. O di ba? Naalala pa yung formula. Blood pressure is equals to cardiac output times total peripheral resistance. So, pag dumikrease yung total peripheral resistance, so, dapat mag-decrease yung blood pressure. Pero during pregnancy, mataas yung blood volume mo. So the increase in blood volume would lead to increased venous return, increase in stroke volume due to Frank-Starling mechanism, increased cardiac output, increased BP. Pero decrease in 3PR. So nag-decrease yung total peripheral resistance mo dahil sa smooth muscle relaxation during pregnancy. Tapos tumaas din yung cardiac output mo dahil sa increase in blood volume. Yung mangyayari, no change. Na-normalize, parang na-equalize, na-neutralize yung decrease sa increase. Decrease TPR sa increase. Kaya normal, no change. Except na lang kung may talagang hypertensive yung patient. So, a 20-year-old female presents with extreme tiredness, shortness of breath, especially with activity, and leg edema. So, workup revealed that her pulmonary vessels are severely narrowed. Ayan, pulmonary vessels resulting in pulmonary hypertension. Alin yung correct? Left ventricle fills ahead of the right. Bakit? Nasaan ba yung problem natin? Yung problem is pulmonary vessels. Sobrang narrowed kaya may pulmonary hypertension yung patient. So pag may pulmonary hypertension, left ventricle ba yung nagfe-fail muna? Eh di ba pag pulmonary hypertension, mataas yung afterload sa pulmonic circulation. So may hihirapan mag-pump yung right ventricle to the pulmonic trunk, to the pulmonary arteries. Kasi mataas yung may pulmonary hypertension. So dapat right ventricle fills ahead the left. Baligtad. So hindi yan. Oxygenation of the blood remains adequate. Venous return decreases or the blood flow in the pulmonary capillaries is high. So the correct answer is venous return decreases. Kasi nga, mataas na yung pulmonary, yung afterload mo sa pulmonary circulation mo. So, hindi masyado mapapump yung blood from the right ventricle to the pulmonary trunk. So, ang mangyayari, pwedeng mag-accumulate yung blood sa right ventricle to the right atrium and mas tataas yung pressure sa right atrium mo, mag-decrease yung venous return. Blood flow in the pulmonary capillaries is high, hindi. Konti nga lang yung napapump ng right ventricle kasi may pulmonary hypertension. So a man was rushed to the ER due to stab wound. The nurse noted that there was massive blood loss and no urine output. Ayan yung clue mo. Massive blood loss, walang urine output. Alin dito yung significantly affected? These are your Starling's forces. So yung clue mo, massive blood loss, nawalan ka ng blood volume. Dahil wala kang blood volume, nagkaroon ka ng anuria. Wala na rin urine output. So alin yung affected? Capillary hydrostatic pressure ba? Plasma oncotic pressure or interstitial? So, the answer here is A, capillary hydrostatic pressure. Siyempre, nawalan ka ng blood volume. So, konti na lang yung blood na mag-flow sa capillaries or even to your uh, renal, your kidneys. So, kung decrease yung hydrostatic pressure, decrease yung blood volume mo, hypotensive ka. Decrease yung capillary hydrostatic pressure, wala kang blood volume. Yun lang. Hindi naman affected yung plasma proteins kasi nga wala namang proteinuria or hindi naman affected yung liver. So, hindi yan yung affected, hindi rin yung interstitial kasi more on blood loss tayo. Kaya, blood volume, basically, yun yung hydrostatic pressure mo sa capillary. Okay. Next, we go on to respiratory physiology. Ayan. Diretso straight na tayo again for the questions. So, the use of beta-2 agonist among asthmatic patients will lead to a decrease in airflow, airway resistance, elastance, or compliance. Beta-2 agonist, asthmatic patients. Di ba, beta-2? Ano nga yung beta-2? Di ba sa sympathetic? Tapos sa lungs, beta-2. Dalawa yung lungs mo. Beta-2. So, agonist, stimulate mo yung beta-2. Will lead to decrease in airflow? Hindi. Kasi magkakaroon ka ng bronchodilation dito. So, dapat increase in airflow. Decrease in airway resistance? Yes. Nabawasan mo yung resistance. Kasi nag-bronchodilate ka, so lesser resistance, more airflow. Hindi rin elastance, hindi rin compliance. The major determinant of airway resistance is the length of the airway, the radius of the airway, viscosity of the gas, thickness of the airway wall. So the answer here is your radius. Radius of the airway, yan yung major determinant ng airway resistance. So di ba bronchodilation, bronchoconstriction. So radius ng airway, yun lang. Yun ang need to tandaan dito. So these are true about the lung interstitium. A, it controls the solute movements between alveoli. It contributes to the framework of the alveoli. It contains collagen or the all of the above. So lung interstitium na tayo. Lung interstitium ba? Solute movements, framework, collagen. So yes, tama naman. Solute movements between alveoli, di ba? Lung interstitium, framework, and yes, may collagen din dyan. Ayan, holding one's breath is impossible due to increase in pH of the blood. Pag increase yung pH, nagiging basic. And here's a beer will stimulate respiration ba? Increase, parang hindi eh. Increase in partial pressure carbon dioxide strongly stimulate respiration. Pwede. Decrease oxygen, respiration, not really. Decrease PCO2 stimulate respiration. So the answer here is letter B. Pag mataas yung partial pressure carbon dioxide mo, yan. Pag mataas yung carbon dioxide, di ba? More on acidic yan. So, more an acidic pH, tapos mataas yung carbon dioxide mo, mas-stimulate yan yung respiratory centers mo to respirate. Di ba? Kaya yan yung nagkakaroon ka ng hyperventilation. Kaya pag may acidosis, yun, pwede yan magkaroon ng hyperventilation. Para mabuwasan. Kasi pag nag-hyperventilate ka, na-stimulate yung respiration, tinatanggal mo yung carbon dioxide. You're decreasing carbon dioxide so that hindi na maging acidic yung blood mo. So, yan. Impossible siya because mas-stimulate yung respiration. How about this? Matching. Matching type. So, we have the respiratory problem and the VQ ratio. So, pag sinabi mong VQ ratio, that's your ventilation and yung Q is your perfusion ratio. Sige, try natin sagutin. So, pag total respiratory paralysis, talagang paralyzed na yung respiratory mo. Nagkakaroon ka ba ng ventilation or hindi na? So, alin dyan? Yung VQ ratio ba? Low, high, zero, or infinity? Pag small airway obstruction. So, ang problem dito, airway obstruction. So, anong problem dito? Obstruction. Ventilation ba? Kasi pag sinabi yung ventilation yan, yung airways na napupunta sa alveoli. Yes, affected yung ventilation. Kasi small lang. Bronchoconstricted yan. Or may obstruction. So, affected yung ventilation mo, decreased. Pag nag-decrease yung numerator, madi-decrease yung ratio. Hindi naman affected yung perfusion kasi wala namang affected na blood vessel. How about 91? Decreased pulmonary blood flow. Ayan. Ito na yung perfusion, yung Q. So, nag-decrease yung pulmonary blood flow, di-decrease yung perfusion mo, di-decrease yung Q. So, tataas yung ratio mo. Di-decrease yung denominator eh. How about the complete tracheal obstruction? Oh, completely obstructed na. So, ano na yan? Zero na din. So, yung total respiratory paralysis is C. Zero na yung ratio kasi, ayun lang, tatandaan nyo. Respiratory paralysis. Wala nang ventilation, hindi ka na makakahinga. Hindi na magkakontract yung diaphragm mo. Hindi na makakapasok yung air. Wala nang ventilation sa alveoli. Ayan. V is the amount of air entering the alveoli. And perfusion is the amount of blood flowing to your alveoli, your pulmonary. So, ayan. Problem ito sa ventilation. So, pag bumaba yung ventilation, ano mangyayari sa ratio? Decrease yung numerator or magiging zero actually. Wala na talaga. Total. Paralysis na talaga. Pag zero to, ayan, zero na. Pag zero yung numerator, zero na. Small airway obstruction. Oh, yung problem din dito again, ventilation lang. Obstruction sa air entering the alveoli. So, obstructed yung airflow. So, decrease yung ventilation mo. So, ano mangyayari sa ratio, sa BQ ratio mo? Low. Dumikrease yung numerator mo, di-decrease yung ratio. Ganun lang yun. Again, decreased pulmonary blood flow is B kasi Q na yung problem yan. Q, yung perfusion mo. Decrease yung pulmonary blood flow, so decrease na lang yung perfusion mo sa alveoli. So pag nag-decrease yung perfusion mo, ano mangyayari sa ratio? Tataas kasi normal pa rin yung ventilation. So increase or high. High ito. Baba lang yung yung perfusion. Complete tracheal obstruction, zero na rin. Complete talaga. Wala nang makakapasok na air sa lungs mo. So affected yung ventilation. Wala akong ventilation. So normal pa rin yung perfusion. Ventilation lang yung affected. Yung amount of air entering the alveoli. So zero din yan. As in total, wala na talaga. Complete na. Metabolic alkalosis is seen in patients suffering from metabolic alkalosis. Siyempre, madali na to. Severe vomiting pwede. Nagbe-vomit ka. Nawawala yung mga acid. Ayan. Severe vomiting, decompression sickness, hypoaldosteronism. Hindi. So, severe vomiting lang. Medyo madali na yun. Kasi pag nag-vomit ka, nawawalan ka ng mga hydrochloric acid and other ions. So, ang problem niyan, metabolic, hindi lungs. So, metabolic alkalosis yung mangyayari if you have severe vomiting. Which of the following is responsible for stimulating the diaphragm during normal quiet ventilation? Ayan. So, dapat alamin niyo yung mga center na yan, pneumotaxic center, apneustic center, DRG, and VRG. Usually, DRG yung pinaka-importante. So, for stimulating the diaphragm sa normal quiet ventilation, that's actually your DRG. Next, we have a 21-year-old female suffers from metabolic acidosis due to salicylate toxicity, which chemoreceptor is stimulated, resulting in ventilation. Metabolic acidosis. Okay. Chemoreceptor stimulated, resulting in increased ventilation. Juxta-alveolar receptors, bronchial irritant receptors, carotid, and aortic sinuses are carotid and aortic bodies. Di ba yung carotid and aortic bodies, ayan, chemoreceptors yung nandyan. Aortic bodies, yung aortic sinus, more on blood pressure yan eh. So, baroreceptor. Aortic bodies and carotid yan. Yan yung chemoreceptors. Yun yung ma-activate. Hindi itong juxta-alveolar, hindi yung bronchial irritant, but more on the chemoreceptors, carotid and aortic bodies. Ito, which of the following facilitates the Bohr effect? Pag sinabing Bohr effect, ito yung shift to the right sa oxygen dissociation curve. Increase ECF, extracellular fluid pH, so nagiging basic. Increase tissue partial pressure carbon dioxide, decrease plasma hydrogen ions, decrease 2,3-DPG. So yung Bohr effect, again, ito yung Bohr effect. Ito yung oxygen dissociation curve, normal. Pag sinabi mong shift to the right, may increase in P50. Tandaan niyo yan. Pag mataas yung P50, meaning niyan, lower yung affinity ng oxygen sa hemoglobin. So, i-release na yung oxygen papunta sa tissues. So, that's why increase yung P50. Tapos, yung mga factors associated with Bohr, pag sinabi yung Bohr, yung R dyan, shift to the right. Pag shift to the left, ito naman, Haldane effect yan. Left Haldane, di ba? Bohr, right, shift to the right. Ayan. Pag shift to the right, ganito lang yung tandaan nyo. Especially nangyayari to sa mga actively metabolizing tissue, di ba? Pag may increase in temperature, syempre, actively metabolizing. Yung tissue, mataas yung temperature, shift to the right yan. Syempre, pag actively metabolizing yung tissue mo, yung isa sa mga waste products, di ba, is carbon dioxide. So, tataas din yung carbon dioxide. Ginagamit yung oxygen, tapos nagiging carbon dioxide. So, tataas yan. So, mataas yung carbon dioxide sa actively metabolizing cell, di ba, pag mataas yung carbon dioxide, nagiging acidic. Kaya yan, low pH siya. Tapos pag actively metabolizing cell, mataas yung 2,3-DPG. Itong 2,3-DPG, ano siya, part siya intermediates po sa glycolysis. So, syempre, pag actively metabolizing yung cell, ginagamit yung glucose, ginagamit yung oxygen for glycolysis para may ATP. So, yan. Mga byproducts, CO2, dahil mataas yung CO2, nagiging acidic yung pH, naglo-lower yung pH, lahat yan shift to the right. Opposite lang naman kapag shift to the left or your haldane. Haldane ito. So, ganyan. So, the answer here is increased tissue carbon dioxide. Which of the following is true regarding your arterial blood gas? So, madali na yan. Normal arterial pH is 7.45 to 7.55. It measures the amount of oxygen bound to hemoglobin. So, hindi. Neither. Ang actual arterial pH mo, di ba, is 7.35 to 7.45. Tapos yung arterial blood gas measures the amount of oxygen bound to hemoglobin. Hindi. Oxygen saturation ata yun. Hindi siya sa arterial blood gas. Kasi partial pressure or yung mga arterial pressure yung dinedetect sa ABG, di ba? So, neither. So, a normal medical student decides to inhale pure oxygen via nasal cannula at 6 liters per minute. If he breathes normally, which of the following is true? Normally. So, normal medical student lang. Normal naman, walang condition. Nag-breathe lang siya ng pure oxygen. So, nag-breathe ng normally, alin yung true? Tataas ba yung saturation? Yung partial oxygen ba tataas? Both or neither? So, the answer is B lang. Hindi saturation. Kasi yung oxygen saturation more on sa hemoglobin yan. Diba? Pag na-saturate mo yung hemoglobin, yun yan. Saturated na talaga siya. Diba yung autosat natin nasa mga normal range, 95% to 100%. So, kung normal naman siya, walang problem sa lungs, tapos nag-inhale siya, wala. Hindi naman mag-i-increase kasi normal naman yung state niya. Pero yung partial pressure oxygen, yun yung i-increase kasi tumaas yung oxygen, yung partial pressure ng oxygen yung tataas. Hindi yung saturation kasi saturated na in a normal medical student, normal patient. So far, yun lang po yung kaya. Hindi ko na na-add yung GI and renal tissue kasi nakulangan ako sa oras. So, sorry for that. So, ito yung mga ginamit kong reference. You can use your BRS din. Good summary din yan. Usually, ginagamit din sa PLE, di ba? Pero ito talaga, Guyton and even Bern and Ledy. Or if you want to understand yung mga detailed explanation, you can watch Ninja Nerd channel para mas maintindihan nyo talaga yung mga concept na gusto nyo ma-until. So far, that's it for the visual lecture.
Thank you so much po.
So here pala yung, if you want to get the PDF copy, of this PDF. Wait, share ko na lang sa chat kung if you gusto na yung PDF.
All right, thank you so much, Denzel. So, for our certificate of appreciation, the FEU NRMF Medicine Honor Society presents the certificate of appreciation to Denzel James Donor. In grateful recognition for his knowledge as a student, mentor, reviewer, in Practa Compre review series conducted today. Thank you so much, Denzel. How are you guys? Did you guys learn? How is it? Thank you so much, Denzel. Let's give Denzel a round of applause. For Pharma later at 1, you could just stay here. You could just park if you're gonna go to Pharma later. Or you could just go back in. Okay, thank you so much.
Thank you.